it's not in the, it's only in the PPT mode only.
नहीं,
This is
मैंने
a,
वापस छोटा कर दिया वो अभी।
okay, fine.
हाँ, अभी अनशेयर आ जाना चाहिए। अच्छा, अभी तो नहीं है ना, अभी वापस शेयर नहीं हो रखा है। चलो, उस टाइम पे फिर हो जाना चाहिए। थिंग्स शुड बी ओके।
अभी तो दिख रहा है सर, स्क्रीन में तो आपका ही आ रहा है।
अभी आ रहा है?
या
हाँ,
व्यूइंग द स्क्रीन, या
मैं कर दूं सर अनशेयर?
हाँ, अनशेयर कर दो।
मैं कर देता हूँ। ओके।
हाँ, now it is not there. Now it is fine. Good evening, Dr. Sumit. Good afternoon, sorry. Good afternoon, Dr. Vinita.
Good afternoon.
Good
हेलो
afternoon,
डॉक्टर
Dr.
विनीता।
Richa. Good afternoon.
Good afternoon, Dr. Kaushal.
हेलो डॉक्टर कौशल।
Hi, sir.
हेलो डॉक्टर गिरीश। आई कैन सी नंबर ऑफ पीपल हैव नाउ जॉइंड।
It's two, shall we start? It's 2 minutes. We just start in 2 minutes. Hello. I think everyone has joined. We can start at 2 o'clock. All the people have joined. What do you say, Dr. Bhanu? Shall we start?
I think अभी some of the participants also have not joined. You said the number of participants were a little higher. Let's wait for
Yeah.
maybe 2 minutes and
Okay. Okay.
Good afternoon.
Good afternoon, everyone.
रविंद्र भाई नमस्कार. रविंद्र भाई नमस्कार.
Hi, sir. Good afternoon. Good afternoon.
Hi sir, good afternoon, welcome.
हेलो बॉस. हेलो, आवाज आ रही है मेरी?
हाँ जी आ
डॉक्टर
रही है.
विकास, आपकी थोड़ा सा आवाज ब्लर्ड आ रही
ब्लड आ रही है ना?
सर नाम भी अपना थोड़ा चेंज कर लीजिए.
नाम चेंज करता हूँ. तो नाम क्या चेंज करता? फिर वीडियो बना.
हाँ जी.
I think Dr. Richa, we can start now. Otherwise,
Yeah,
we
it's 2:05 already, so that sessions will not be late. Yeah. So at the outset, very good afternoon to everyone. At the outset, I would like to thank all the faculty, chairpersons, speakers who kindly consented to be part of the meeting. Also thankful to all the delegates who showed interest in these topics. Pediatric endocrinology as a branch is useful in day-to-day practice, but we usually keep discussing about growth and puberty issues. Apart from the issues of growth and puberty, as a child grows, adolescent issues make an important part too. So we decided to concentrate on these topics related to adolescent endocrinology. So panels. At the end of each session, there will be 2 questions for the audience and delegates. I request everyone to participate in the discussion and for question, answer them in the chat box. During the sessions also, you can keep typing the questions in the chat box and we will take them in the question answer sessions. I hope all of us have a great learning experience today. So now I request Dr. Bhanu to say a few words.
Yeah, thank you, Dr. Richa. And at the outset, the first thing is thank you for making all the efforts for organizing this important meeting because adolescent endocrinology is certainly an area which every pediatrician quite often see in their usual office practice. And there are several issues which are there which often keep bothering you while taking clinical decisions. And many a times they may not be very difficult, or but the only thing required is a meeting like this where we can talk about them and update ourselves with the current guidelines. And all the credit for this entire effort goes to Dr. Richa. Which it's a fourth edition of ENDOCON, and now that we all are versed with online meetings also, so it is possible now in this way. So without further ado, let's start with the first session, and it's my pleasure to introduce the chairpersons of for the first session. The first session is on gynecomastia, and our chairpersons are Dr. GP Kaushal. Dr. GP Kaushal is head of the Department of Pediatrics at Dr. Ambedkar Medical College, Delhi, and he has been active as an office bearer in Delhi IAP, and he has a number of national and international publications. Our second chairperson for this session is Dr. Vinita Jain. Dr. Vinita is senior consultant at Aadhar Hospital in Hisar, and she is quite active in her field and a known personality in that region. And our next chairperson is Dr. Girish Arora. Dr. Girish is senior consultant and director at Rainbow Hospital, Panipat. He is quite an active personality in the sphere of IAP Panipat, and has been office bearer for past several years. And his key area of interest include vaccines, and he has taken a lot of initiative in meningococcal prevention committee as well. So hand over to you, chairpersons.
Thank you, sir. I'm Dr. GP Kaushal. Very good afternoon to all of you. At the outset, I congratulate Dr. Richa for taking such a step that this adolescent endocrinology is really a subject which everybody should have some knowledge. And I welcome Dr. Ravindra for speaker for the day, who will be speaking on gynecomastia. Dr. Ravindra is a trained endocrinologist from AIIMS and currently is in charge pediatric endocrinology and neonatal division, Hindurao Hospital, and is also principal guide to TNB student, and is currently president IAP North Delhi. And he is also very active member in Indian Society of Pediatric and Adolescent Endocrinology. And he will be speaking on gynecomastia. No doubt it's a benign thing, and it's normally self-limiting, but it can be sometimes very psychologically pressing and physically uncomfortable to the adolescent. I request Dr. Ravindra to start. Any of my co-panelists want to contribute something, most welcome. Or Ravindra, you can start, sir.
Thank you, Kushal sir, and all the chairperson. Good evening, all. Thank you for your kind words, chairperson sir, and thank you, Dr. Richa and Dr. Bhanu, for giving the opportunity to be here with all you. Very elegant and prominent personality. I would request Dr. Richa to please project my PPT, because Dr. Richa is having all that presentation. Dr. Richa, you are there?
Post now, yeah. She's there, sir. She's doing something.
Dr. Richa, can you project?
Screen share कर दीजिए, ma'am, please.
Just a minute. Actually, my connection had got lost in between.
Yeah, it's
Still, Dr. Richa is sharing the presentation.
yeah, it's
Can you
Yeah.
use the mic?
yeah, it's shared, sir.
It's is it
Thank you, Dr. Richa. Next, please. Today's topic is gynecomastia. Why and I. Next, please. Yes. So, as our chairperson has said, it's very benign most of the time. So, what exactly is gynecomastia? It's a benign proliferation of glandular tissues of the breast in male. We all know because it is in the male. It may be unilateral or bilateral. Mostly, it is the bilateral. If it is unilateral, then we have to be very careful. Then probably something pathological we are dealing. If it is unilateral, gynecomastia has to be distinguished from the pseudo one. Reason being nowadays when obesity is so rampant that even the fat tissue they present as someone is having the prominent breast tissue. So and it is the lipomasia which is characterized by excess fat deposition. If you look at the profile of gynecomastia, usually it has three very discrete peaks. One is when in the infancy or neonatal period, second during puberty, and third is middle-aged or adult elderly man. However, we will talk about today only about the neonatal and what is there during puberty. If we look at the gynecomastia of infancy or neonatal, I mean, can we go to the previous one, Dr. Daricha? Just to wait.
this is fine?
Yeah. So this is a condition which is usually resolved spontaneously and typically within the first year, but within couple of weeks. And I mean, because we all are pediatrician, we deal with the neonates. We may be any dealing with any specialty, so it is very very common. If you look at the gynecomastia of puberty, it is again very common, approximately 50% of the mid-pubertal boys. And if you look at the incidence of an escort from 4 to 49%. However, to be very relaxing, that in more than 90% of cases, it resolves spontaneously, again within few minutes, and definitely within 2. However, within few months. Next, please. It develops in 65 to 90% of all newborns. So means you can assess how common it is and possible consequences. It is because of the estrogen, progesterone, and hematographic peptides, which is there because of the intrauterine milieu through the placenta. Usually it resolves within a few weeks after birth, coinciding with the withdrawal of maternal hormones from the neonatal circulation. Sometimes this gynecomastia of newborn, it may persist or even reappear in the first month of infancy when it is during the mini puberty period. We all know that in the mini puberty period, male have almost the same level of hormones which is there at the puberty, at the time of puberty, and which persist usually up to 6 months. So it may be because of that, which is a transient activation of hypothalamic pituitary and gonadal axis. However, gynecomastia of infancy is not associated with any sequelae or abbreviation of development and typically does not persist after the first year of life. So what is required is just reassurance. Next, please. So now coming to the adolescent, as I already said, the incidence is somewhere from 4 to 69%. It usually present at 10 to 12 years old and peaks at 13 to 14 and usually regress within 18 months and is uncommon in male age 17 and older. If it is persistent more than that, obviously we'll think about some pathological cause and accordingly we'll investigate the patient. Very interesting that some pubertal boys they experience that intermittent gynecomastia. So regular follow-up and counseling is what is required and needed. Undoubtedly, underlying endocrinopathy usually not detected in vast majority of cases, and spontaneous regression can be expected within the first 6 months of this gynecomastia or less. However, may persist up to 1 to 2 years. However, if it is more than 1 year, then we have to be very careful and have to investigate accordingly. Next, please. If you look at the pathology, so we know they are the two hormones, either gonadotropins or estrogen and progesterone. So it is basically the misbalance of that. So the major cause of gynecomastia is altered imbalance between estrogen and androgen effects, which may be either there is absolute increase in the estrogen production, or alternatively there may be a relative decrease in the androgen production. Hence, the ratio of estrogen and androgen will change and will cause gynecomastia. Overt androgen deficiency or estrogen excess may be detected in someone. However, occasionally the ratio which I just said is usually which is the abnormal. And this is despite the presence of the normal concentration of both sex hormones. If the androgen is diminished, may be a result of primary or secondary T means testosterone deficiency. However, in rare cases, maybe because of the insensitivity of the androgen receptors. Estrogen excess, it may follow increased production either from the gonads or adrenal, maybe because of the increased peripheral conversion of androgen to estrogen. This is very, very important nowadays. Again, because of the obesity is very common. So in the adipose tissue, there may be more aromatization of these androgens or the administration of exogenous estrogen. So we have to take a very proper care history and very careful. Reason being, there are many fairness cream nowadays which may have estrogen. So that may be the reason. Next, please. I mean, these are the pathological mechanisms that either may be increase in estrogens, which may be direct, or extraglandular aromatization of precursors we just talked about. Decreased metabolism may be there, and exogenous administration, which we have to be very careful about the exogenous administration. Decrease in endogenous free androgen, which may be either because of the secretion or the metabolism of these androgens may be increased, which may be in various disorders like the hepatic disorder and renal disorders, or there may be increased binding to sex hormone binding globulin, or maybe the altered serum androgen estrogen ratio. There may be puberty, aging, refeeding, gynecomastia. This is again in many GI surgeries where refeeding is being done. So that may be a result of that. Hepatic cirrhosis, hypothyroidism, couple of disease, drugs, renal failure, and sometimes dialysis. Next, please. These are the causes of gynecomastia, as it may be physiological, as we have just said, neonatal or infancy, puberty, or middle or advanced stage. If you look at the pathological, again, medication, there are a couple of medications or primary testosterone deficiency. So we have to be very careful. Maybe dealing with the Klinefelter syndrome. Just look at the height of the patient. If it's having extraordinary height, the parent may be happy, but it may be some syndrome like Klinefelter syndrome, or maybe secondary testosterone deficiency, hypothyroidism, class, hepatic causes, malnutrition, and just couple of rare causes. Androgen insensitivity is one of them. Sometimes through hermaphroditism, which result because of environmental polluting substance. Nowadays, these endocrine disruptors are much talk of the town, and we have to be very careful. There are so many drugs, so many tonics are available, which may have one of these things, estrogen, and probably which is causing parents are thinking that increasing height is because of that tonic or whatever supplement has been given. So we have to be very careful while dealing with these people. Next, please. 。 . 。 。 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 When we talk of the drug, some of the drugs, for example, digoxin, metronidazole, spironolactone, metoclopramide for vomiting, or isoniazid for tuberculosis. These are the, although all the whole list of the drugs, but these are the commonly used drugs. We have to be careful while knowing the cause of the gynecomastia. Next, please. While evaluating, yes, which is very, very important, we have physical examination and then couple of investigation. As already said, most gynecomastia is asymptomatic and is mild. And when it is found incidentally on examination in isolation, usually don't warrant evaluation, just close monitoring and counseling of the patient. Have a careful history, as I just enumerated about medication. Physical examination usually identify what are the potential predisposing conditions may be there. Medication causes gynecomastia. Clinical evaluation should focus on, can it be there any androgen deficiency, or patient is taking any tonic, immunity booster, which is a prescription available over the counter. Substance abuse nowadays in adolescents, or herbal or nutritional supplements, cosmetics, all these dietary intakes. We have to be very careful about signs or symptoms of any systemic illness related to hepatic or renal disorder. As we have just said, it increases the secretion of gonadotropins or endocrine disorders like hypothyroidism, cortisol excess, adrenal disorders. History of recent recovery from malnutrition, severe weight loss, or chronic illness is again important. Next, please. There are few basic investigation which could be done if this gynecomastia is number one persisting. Persisting means more than 6 months or year, or if we are thinking of some chronic illness alongside. So basic is testosterone, LH, FSH, and PSH just to look up for any thyroid disorder. LH and FSH just to look imbalance between testosterone and LH and FSH. Renal and liver function test, estradiol, prolactin, and beta HCG. These are the few investigations which are required when it is persisting more than 6 months or indicating some associated illness. However, if testes are small, patient karyotype should be obtained to exclude Klinefelter syndrome. Again, because patient will be having very good height, apart from that, the size of the testes is small. And if all tests are negative, the patient should be diagnosed with idiopathic gynecomastia, even if it is persisting. Next, please. As far as treatment is concerned, less than 6 months, gynecomastia, spontaneous regression will be there. Nothing is to be required, just close monitoring. In pubertal males, 85 to 90% of cases they regress between 6 months and 2 years, and continuation after 17 years is very, very rare. If it is there, we have to know the cause exactly. If gynecomastia, as already said, persisting more than 1 year and is associated with severe pain, tenderness, or psychological distress, medical and surgical options are available. If it is, what are these? Based on the etiology. If it is drug induced, okay, stop the offending drug, the symptoms will regress. If it is because of some systemic illness, maybe hepatic or renal or hyperthyroidism, treat the causative illness. These symptoms and signs will regress. However, in hypogonadal patient, this is very important. Treatment with testosterone may reduce to regression by producing androgens. However, in some patients, this testosterone again may get aromatized to estradiol, which result in further aggravation of gynecomastia. So these things we have to keep in mind while we are treating these hypogonadal patients. Next, please. Medical treatment, although complete regression is unlikely. However, what they are doing giving the symptomatic relief, psychological relief, and yes, obviously will provide some partial regression. And the major medical intervention option, androgen, testosterone, and danazol. Danazol, we all know. Many times we use it when parents are very apprehensive or if it is persisting. Dose is again somewhere 100 to 200 milligram. Anti-androgens, tamoxifen, although it is a very milder one, but yes, sometimes in combination, danazol and tamoxifen both. Dose of tamoxifen is again somewhere 10 milligram or 20 milligram, usually 10 milligram. Aromatase inhibitors, anastrozole, and testosterone may be used. Next, please. Surgery. Although surgery is definitely not recommended for neonates, not at all, and even not recommended in adolescents until the testes has reached the adult size. Reason being, if it is done before that, then it will recur because all the imbalance will always be there. The most commonly used technique is again subcutaneous mastectomy. Sometimes liposuction alone is being done, which may be sufficient if it is because of the excess fatty tissue. Very important to note that even if we are doing surgery, the results are cosmetically unsatisfactory in 50%. Hence, there is hardly any. Next, please. So thank you very much. Just concluding this slide with this one, that gynecomastia is not if someone very serious or critical disease most of the times. And what we have just to do is just counseling of the parent and a very good follow. It will spontaneously regress within a few months. Thank you very much.
Thank you, Manish. It was really nice talk. Finished well within time. Just one thing I wanted, there was word written refeeding gynecomastia, sir. Just to comment on that.
So
Refeeding.
these are the surgical cases. There are many times, when GI surgery are done, so because of the malnutrition, all that, the refeeding that is why I just at that time I said. So sometimes it has been seen in that there is some hormonal imbalance causing gynecomastia.
Are there any red flags in this about gynecomastia when one should be overcautious or take some expert advice?
Yeah, I just said if the size of the testis is small, we have to be very careful. Are we dealing with the clean pelvic? Patient height will be very good. Parents are very much satisfied. However, when you examine properly, because we just see either this gynecomastia is exactly gynecomastia, this is not gynecomastia, number one. Number two, all the gonads, they are there. This is the one. And third is sometimes, it may be complete SWAR syndrome, complete androgen insensitivity. So, so basically, but having the whole breast development.
Thank you. Nice talk.
Yeah, I have a question.
Yeah, please, Dr.
Is the size of the breast in when the patient is having gynecomastia is linked to the cause? Like if it is
Usually it is for the adult one. That size are made for adult. When it is in late adult, in adult and in adolescent wise, this is just the
Dr. Ravinder sir.
Ji sir, ji.
Sir, excellent talk. Nothing to add on subject. One thing I would like to just ask you, what is your personal experience about drug therapy, especially with tamoxifen and danazol in some patients?
See, tamoxifen I have not used. Danazol, yes, when I was at AIMS, we have used in few of the cases because parents were very apprehensive. So we have used it. And anyway, spontaneous regulation has to be there. When it is idiopathic, nothing has been came out. So yes, there was improvement, but I think if even we have not given, the patient would have improved even that.
That is the catch now only. Whether we, when to stop and how to start, these are the some ethical issues which are often we face in the office practice. So how to address these issues?
Ethical issues will always be there, because I still remember one of the patient case where he was to, get admission in Navy. And there, when he was having this gynecomastia, and he was a adult male, I think 17 or 18 years, and he was having this, and all the investigations was normal. We advised surgery in that case. So these are the certain issues, because he has to go to Navy, and Navy won't allow this all when on medical exam.
So in
Otherwise,
nutshell,
gee,
There's
in
one
nutshell,
question in the chat box.
Yeah,
But Dr. Chatri wants to answer. Actually, he is tired. What is the most common cause of true gynecomastia? And what is the incidence? And if it is spironolactone induced, what is the dose and is it age related?
I mean, I try to find, there are so many drugs are there. Just when they are, it has been written, okay, when it has been used on a longer duration, they may cause gynecomastia. So if someone is on having gynecomastia and he's found to having spironolactone, which is otherwise safe, right? And we are using so much, especially in patient of who are having CHF. So we
And
have to just to stop that.
good thing
Stop the drug.
it's reversible now once you
Yeah,
stop.
it is reversible. When you stop the offending drug, the patient will have the relief of time.
I think with this we can move on to other session. Thank you, Dr. Ravinder. It was really nice and interactive session. Now over to Dr. Richa, please, ma'am, for the next session.
Dr. Ravindra, there's just one more question in the chat box. I will just take that. There is an obese patient, how to differentiate between fatty tissue or a glandular tissue?
You have to do the breast examination from the side of the breast. Slide your finger towards the center. If it is glandular tissue, you will find the resistance and hindrance. If it is fat, you won't find any resistance. So this is very important question, because we have to differentiate. Lipomasia, nothing has to be done. Just you have to counsel the patient.
Yeah.
Dr. Ravinder, one last question from my side.
Yes, sir.
Dr. Ravinder, am I audible?
Yeah, absolutely. You are audible.
We talked about spironolactone. Does spironolactone in female children cause similar type of mammary gland enlargement?
In female patients, because I love to see this from the literature. I have not searched in that way, but yes, spironolactone is supposed to, increase the glandular tissue. So I don't think there is any reason that will spare the female one. It has to be there also.
Thank you.
Okay. Thank you, Dr. Ravinder, for a very insightful session. And thank you for all the delegates for having a very active. I hope if you have more questions, we can put in the chat box and we can take it subsequently. So we move on to our next session. This next session is polycystic ovarian disease like symptoms. So this is a very common thing that we observe in adolescents. For this, I invite Dr. Manish Gupta for chairing the session. He is a senior pediatrician and neonatologist at Jaipur Golden Hospital and has been the general secretary treasurer of IAP Delhi. He has been an IAP trainer for multiple modules. So over to Sir Dr. Manish.
Thank you, Dr. Richa. So now we have a discussion on a very important topic, which definitely we all pediatricians see in our clinics. But it's such a mix of symptoms that affected menstrual disorders, presenting with acne and everything, and we definitely miss out, and we don't know as a general pediatrician how to approach and to learn basically what pediatrician can do and where this patient had to be optimally and rightly referred. We move on to our expert, Dr. Bhanu Bhakri. Dr. Bhanu, we welcome you, and he is the co-organizing secretary of ENDOCON. And really thank to Dr. Bhanu and Dr. Richa for over the time these years organizing ENDOCON and enhancing our knowledge on pediatric endocrinology. And to tell you about Dr. Bhanu, he is Professor Pediatrics and Pediatric Endocrinologist at PG Institute of Childhood, Noida. And he has done his MD Pediatrics from PGI Institute, Chandigarh, and PDCC Pediatric Endocrinology from Lucknow. So over to Dr. Bhanu for this session. Thank you.
Thank you, Dr. Manish, for this kind introduction. And I totally agree. You rightly said that there are a number of this topic is very interesting and quite frequently faced by pediatricians in general. But somehow it's my perception that since we pediatricians our basic training is doesn't include the emphasis never goes much on the like menstrual irregularities and those things. So somewhere we are not very very comfortable in making decisions for such situations, and so these topics are more considered of adult and gynecology colleagues belonging to them. So that's why it's important that we should discuss this topic, and I'm sure that it is going to be very fruitful discussion today. I'll just share my screen. Is it visible in slideshow mode?
Yeah, it is.
Yes,
Okay.
sir.
Great. So, first of all, it's my privilege to introduce our panelists for today, and they actually require no introduction. All three of them, they are quite active in the field of pediatrics as well as in pediatric endocrinology. Our first panelist is Dr. Ganesh. Dr. Ganesh is Principal Consultant Max Healthcare in Saket and Gurugram. And he has been an office bearer of his pay. A number of index publications and book chapter he has in his credit, and some of the impressive credits are he has been a co-author in SPAD 22 hypoglycemia guidelines, as well as being an editorial committee member for congenital hypothyroidism guidelines by ISPE. Our next panelist is Dr. Preeti Singh. She is Professor of Pediatrics at Lady Hardinge Medical College, and she also has a number of research papers and books in her credit. Along with that, she has been a core committee member of prestigious ISPE Ideal Program and Best Program, as well as she has been this executive board member in ISPE Council and treasurer for Pediatric and Adolescent Nutritional Society. And next panelist is Dr. Sumit Arora. Dr. Sumit is Senior Consultant Pediatric Endocrinologist at Artemis Hospital, Gurugram. And she is a fellow from Diplomate of American Board of Pediatric Endocrinology. And her area of interest is clinical obesity. And apart from a number of publications and research works, she was awarded, she has an awarded research work in Diabetes Distress Quality Improvement Project. So welcome panelists, and let's start with our questions. So our first question is for Dr. Sumit. Dr. Sumit, please tell us that what is PCOS and what are the key components of this multisystem disorder?
Yes, thank you, Dr. Bhanu and Dr. Richa for having us here and for your very kind introduction. Am I audible?
Yeah.
Okay, so polycystic ovarian syndrome is a heterogeneous disorder and has very varied presentations. It affects about 5 to 15% of adolescent girls. And what we are seeing is a state of hyperandrogenism, which we cannot explain by any other medical disorder. And to talk about what are the components, so we know that there is a significant overlap between the immediate post-menarchal period and the clinical symptoms and signs of PCOS, which could be anovulatory cycles, acne, and polycystic ovarian morphology. So it becomes very difficult to identify what is PCOS versus what is the norm that we're usually seeing. But the suggested criteria as per the International Consortium update that was published in 2018, are these. So there are two required criteria to diagnose PCOS, and one is the irregular periods or oligo or anovulatory cycles. And second would be any evidence of hyperandrogenism, whether it is clinical or biochemical. We are not using PCOM or polycystic ovarian morphology as a required criteria, and it is an optional criteria that is used in conjunction with the other required criteria. And there is no recommendation to check for insulin resistance or other biomarkers. And we have to keep in mind it is a diagnosis of exclusion, and once we have ruled out other diagnoses, then only we can call it PCOS.
Okay, so so important thing what Dr. Sumit has highlighted here is that the criteria are very specific, and as we were discussing, that most of our understanding about PCOS conventionally has been from what the adult studies say, and I think a lot of emphasis in the adult studies it is given to the PCO morphology as well as number of other parameters like hyper insulin state and metabolic parameters. But in adolescents, it is not taken as one of the criteria. So this Dr. Sumit has already talked about. Yeah.
So when we're talking about irregular periods, in the first year, there is going to be some irregularity that is noticed. So between 1 to 3 years, we consider irregular cycles when the duration is less than 21 days or more than 45 days. And beyond 3 years, we consider abnormality when the duration is more than 35 days or less than 21 days. So these are some criteria that we really have to keep in mind before we call anybody having the adolescent age having irregular periods. Any one cycle beyond 3 months or beyond 90 days is also considered abnormal.
Okay. Okay. So our next question is to Dr. Ganesh. Dr. Ganesh, what are the challenges in making the diagnosis of PCOS in adolescents?
Thank you, Bhanu and Richa, for having me here. So I think firstly, why this question is important? Why is it important to classify correctly? Because PCOS is something that is a label which is likely to carry lifelong, and it has a lot of psychological as well as a lot of clinical implications because there is an increased risk of metabolic and reproductive issues along with hormonal issues. So therefore, the diagnosis has to be made very, very carefully. And if we are not able to, if we think that the person is at risk of PCOS but is not meeting the criteria, we can say that there's a probable PCOS or PCOS risk or something like that. So both are important. Early diagnosis is also important because you can institute the lifestyle changes, dietary changes, etc. At the same time, it is important to avoid overdiagnosis. Now, the confusion arises because many of the clinical features of polycystic ovary syndrome overlap significantly with normal changes that are seen in puberty. For example, some amount of acne are common during puberty, during normal puberty. Also, when you take irregular periods, initially, first few cycles after the menarche are anovulatory. So it is likely that for first 1 year or 2 years, the girl has irregular menstrual cycles physiology. So there's a physiological irregularity of menstrual cycles in the first few months after the menses. Similarly, things such as insulin resistance, etc. In puberty, there can be some physiological insulin resistance. And the most important thing which Sumit also highlighted is that the ovarian morphology can be physiologically multicystic. So just having a polycystic appearance of ovary does not make you have PCOS or a diagnosis of PCOS because it is a normal ovarian morphology in many girls. Biochemically also, there are a lot of issues about the testosterone assays and what level would indicate high androgens, whether free testosterone or total testosterone. Several issues are important to be addressed. One key thing, other than points already highlighted by Sumit, is persistence of symptoms. So if there is, I mean, if these symptoms are persistent beyond 2-3 years, severity of symptoms such as moderate or severe acne, that would more likely to indicate PCOS. I think criteria have already been elaborated. I wouldn't repeat them, just would like to highlight that now we have access to even liquid chromatography methods, and LCMS methods are considered to be more accurate with respect to when we are measuring the steroids. So wherever possible, we should use accurate methods of hormone estimation, and free testosterone assays per se can be unreliable. So therefore, to know the free testosterone, we kind of derive the free testosterone values from the total testosterone and sex hormone binding globulin using indices such as calculated free testosterone or free androgen index. Clinical hyperandrogenism is also indicated by moderate or severe acne or hirsutism. Now, for hirsutism, there is something called as modified Ferriman-Gallwey scoring, which is, I mean, quite elaborate. You usually like not addressed, I mean, not a part and parcel of routine pediatric examination by a general pediatrician. But there are charts available, and any hirsutism that is distressing, is causing psychological problems for the girl, is likely to be significant. All these things, provided the other conditions have been ruled out, such as hypothyroidism, hyperprolactinemia, non-classic congenital adrenal hyperplasia. So these are the challenges and some tips to diagnose polycystic ovary syndrome during adolescence.
Thank you, Ganesh. Our next question is to Dr. Preeti. As Dr. Sumit as well as Ganesh both have pointed out about the importance of hyperandrogenism in this condition. So the next question is that as hyperandrogenism is considered as one of the primary abnormalities, what should a pediatrician know about it? So some of the things they have already covered. So would you like to clarify a bit?
Right. Thank you, Dr. Bhanu sir and Dr. Richa for having me here. So as Dr. Ganesh correctly pointed out, that hyperandrogenism is one of the important key parameter while we are diagnosing children with PCOS. So there are clinical as well as biochemical criteria. So if we look into the literature, almost more than 80% adolescents will exhibit either the clinical or the laboratory evidence of androgen excess. So when we are looking for the clinical criteria, we are specifically looking for either hirsutism or acne or even alopecia. So hirsutism is, as we all know, that is something which is very common during adolescence, right? But when do we actually feel that it is a clinical indicator for hyperandrogenism? So first is, what is hirsutism? So basically any excessive terminal hair growth in a male distribution pattern. That is very important because that is how we differentiate it with hypertrichosis. In hypertrichosis, there is hair distribution, but predominantly on the non-androgen dependent areas. So when we talk about hirsutism, so we try and classify hirsutism based upon a subjective, a semi-quantitative, subjective and visual scale, which is called as a modified Ferriman-Gallwey scale. So as we can see in this figure, so this scale actually points out the distribution of the hair in different parts of the body, and it is visually scaled or scored from 0 to 4. So 0 is absence of hair and 4 is like a typical male pattern of hair. And this kind of a scale can be looked for assessment of hirsutism. So mild hirsutism is something where the score is say less than 8, but now with the latest evidence, we take the scale score as 6 to call it as hirsutism. So between 6 to 15 is a score which is called as a mild hirsutism. So mild hirsutism is common during puberty. So this is something which is not very clinically suggestive of hyperandrogenism, but if mild hirsutism is present along with the menstrual irregularities, which were pointed out well by Dr. Ganesh as well as Dr. Sumit, then particularly we should look for hyperandrogenism. However, if the patient or the child has moderate to severe hirsutism, which is a score which is beyond 15, then we are definitely looking for a sign that is clinical hyperandrogenism. So if you have a scale of hirsutism moderate to severe, please think of PCOS, right? It is one of the important clinical identifier point. Another limitation to the Ferriman-Gallwey scale is, one, it is subjective. Second, it does not take into account the ethnic variation. We know that the people belonging to the Punjabis and the North Indian belt, they have a higher hair distribution as compared to the ones who are coming from Northeast, right? So there will be some ethnicity also, but that is not taken into account in this scale. The third important thing is that all the areas are given equal scale or equal score. That is again one of the important things. And when we see the children in our OPDs, they're all well clothed. So what I would suggest is that you can keep handy such kind of a scale and ask the girl itself that what all points are where the child actually lies in the scale. So that will also give you some identifying features. Another important thing is that hirsutism evolves over a period of time. So if we are looking in the early perimenarchal period, the child may have milder hirsutism, but it evolves over a period of time, right? So it is something which is a clinical indicator, but it evolves. So maybe at first contact, the child might have mild, but later on, if it evolves, then it might become even more significant. So it is one thing which is very important. The other important thing which I would like to highlight is the presence of acne. So acne is something again very common to puberty, but acne, if it is present in a moderate to severe form and inflammatory form, which is typically resistant to topical therapy, then it becomes something like a clinical indicator. And then also I would say it is an indicator of hyperandrogenism, but it may not be one of the clinical criteria to call it as PCOS. So if you have acne and alopecia, that becomes a strong clinical pointer for investigating for hyperandrogenemia. By itself, they may not qualify as clinical indicators for PCOS. So these are the two important clinical features which we should be aware of. Again, alopecia is quantified by using a Ludwig score, which I have not put into the slides, but yes, if we are really interested, we can go into the classification as well. Another important thing which I just want to point out is that the degree of hyperandrogenemia, the biochemical degree, it has actually no kind of, you cannot really correlate the symptoms of clinical hyperandrogenemia with biochemical. So it depends upon how sensitive the pilosebaceous unit is with respect to the androgen production. Now, if we talk about the biochemical evidence, so we are obviously confused most of the time which investigations to order. And Dr. Ganesh very rightly pointed out the important pointers or important things that we need to keep in mind while we are ordering these investigations. But having said that, I would like to just clarify that it is one of the most important, strongest evidence of hyperandrogenemia that we need to really focus upon. So we have options like testosterone, which is total testosterone or free testosterone. But the important point is that we do not have reliable norms for the androgen levels, right? So usually what happens is that after the child achieves menarche, usually the levels of the testosterone, they try rising and they rise to a level of female adult value, right? So we can use that particular reference value, but that is what is more important to understand is that these parameters are evaluated from a reference lab and using validated assays. So if we talk about free testosterone, the ideal way to do it is equilibrium dialysis, which is very costly and it is not available. So short of that, what we can do is we can use the free androgen index, as Dr. Ganesh also pointed out. So free androgen index is a calculated value wherein we put in the total testosterone divided by the sex hormone binding globulin into 100. But again, there is a problem with this assay. The index is that there are no reliable cutoffs to indicate that this is a particular level where we can say this is hyperandrogenemia. So each laboratory will have their own nomograms for it, right? Short of that, I would say total testosterone, if measured using LCMS, that is something which is easily available. In most of the good commercial labs, they are doing it, and that is considered as a gold standard. So what is, again, one thing which I wanted to just point out is that nowadays, we have started using the labs that we have. So if we are using the testosterone value, and by the immunoassays, we can take a cutoff of 55. If we are trying to measure the free androgen index, we can take a cutoff of 3.6. And the calculated free testosterone more than 23.4 picomole per liter can be considered as cutoffs for defining criteria for biochemical hyperandrogenemia in PCOS. Now, other parameters like AMH, testosterone to dihydrotestosterone ratios, they really are not at all supportive. I would say they do have a role, but again, there is a challenge because of the wider ranges that they have and the overlap that they have with the normal pubertal values. So these are usually not done. The gonadotropins level, again, is something that we look for while we are trying to rule out other pathologies like hypo or hyper. But otherwise, for PCOS, these parameters are really not required for making a diagnosis.
Thank you, Preeti. Our next question is about the relation of PCOS with obesity. Now, as we know that there is a very strong association seen among adults and also in the adolescent age group. So how both the things are linked? How obesity, metabolic syndrome is linked with the symptoms and the diagnosis of PCOS, Dr. Sumit?
Yes. Thank you, Dr. Bhanu. So we have to understand that the pathophysiology of PCOS is very complex, and it not only involves insulin resistance, but there is a lot of other factors that go into the pathophysiology, which could include a genetic risk, the epigenetic factors, the neuroendocrine modulators that are playing a role, and of course, insulin resistance. Now, because insulin resistance has a significant role, and the higher the body mass index, it is a harbinger of insulin resistance that increases the risk of PCOS by almost 50% as per several studies. But when we talk about the complexity of the pathophysiology, all obese individuals will not develop PCOS, and all PCOS do not have to be obese. That is very clear, because we do have an entity that is called lean PCOS also, and we also know that all individuals that are coming to us, all women coming to us, do not have irregular periods and do not have hirsutism. I mean, I'm talking about the obesity ones. So yeah.
Okay, so probably that's why it's not included as one of the diagnostic criteria. Yeah.
Yeah.
Okay. So our next question is to Dr. Ganesh. Dr. Ganesh, you are there?
Yes, yes, ma'am.
Okay. What are the usual manifestations of dysregulate? So far we have discussed about the menstrual irregularities and how they're defined and everything, about the clinical manifestations. But what goes wrong at the HPG axis level?
So I think in the previous slide, Sumit showed in an excellent manner how PCOS is not simply, I mean, the name polycystic ovary syndrome suggests as if the primary seat of the problem is ovary. But that is actually not true. Polycystic ovary syndrome is very complex condition. It has a lot of genetic and other biochemical abnormalities. And one of the key biochemical abnormalities also affecting the hypothalamo-pituitary gonadal axis. Now, if we go backwards, if we say that polycystic ovary syndrome has hyperandrogenism, which is in the androgens are produced by theca cells in the ovary, and the theca cells are directly under influence of LH. So there is a LH overactivity as compared to FSH. LH is the predominant hormone that is playing a role in polycystic ovary syndrome. And why this is so? Because LH is further controlled by the gonadotropin releasing hormone. And in polycystic ovary syndrome, it has been shown that there is an increase in the amplitude and the frequency of the GnRH pulses. Now, such a kind of GnRH secretion is associated with increased LH and comparatively relatively decreased FSH. So that creates an environment in which we know the cycle of ovarian follicles, that the ovarian follicle undergo a particular typical cycle leading to ovulation, and subsequently depending on pregnancy has happened, the regression or maintenance of the corpus luteum. So what is happening is that the many follicles are getting arrested at a antral follicle level, and they are not maturing, and therefore the ovulation is disturbed, and the hormonal milieu is such that it is promoting LH excess, androgen excess, and this is happening because of the GnRH excess. And there are this is having for a pediatrician, it may not be necessary to go into the complexities, how the insulin levels And the neurons such as KNDY neurons or kispeptin secreting neurons or POMC neurons influence these pathophysiology. And there might be other yet unknown influences affecting this. So I think for a pediatrician level, it is important to understand that there is excess of LH. So if you do the LH and FSH levels, you will find that the LH levels are disproportionately higher as compared to the FSH levels. And there is a problem in the maturation of the follicles, causing many follicles to be at the similar level of maturity and irregular ovulation.
Okay, yeah. So I think that much is the take home for pediatrics office practice. So next question is to Dr. Preeti. What other conditions should one consider while evaluating any adolescent for possibility of PCOS?
Yeah, so thank you, Dr. Bhanu. So PCOS is mainly a diagnosis, which is a clinical diagnosis. You have the clinical criteria, like we talked about the hyperandrogenic criteria and the menstrual irregularities, and along with some biochemical criteria, right? But there would be some, overlap with a lot of common clinical conditions also. So I would say that you rule out all the other important organic secondary causes before you make a diagnosis of PCOS. Specifically, the common ones would be the thyroid dysfunction and the hyperprolactinemia, right? So even thyroid dysfunction and hyperprolactinemia can lead to symptoms which are quite similar to PCOS. So please rule out by doing a thyroid function test and the prolactin levels. Then the third important cause I would say is non-classic CH, though it is something which is not very commonly seen, but you need to really know that the clinical presentation of a child with non-classic CH, particularly the most common being the due to 21 hydroxylase deficiency, that is something which is very closely resembling symptoms of PCOS. You have virilization, you have hyperandrogenic states, and classically, how do you ensure or diagnose it? You can measure the follicular phase 17-hydroxyprogesterone levels. And sometimes when the levels are in the gray zone, that is between 2 to 10 nanogram per deciliter, in those cases, you might require a ACTS stimulated value for the 17-hydroxyprogesterone. So typically, the adolescent girls will present with features of hirsutism, acne, and they would have menstrual irregularities, again in non-classic CH. Then what is important is that in some of the cases, you have the androgen secreting adrenal or the ovarian tumors, which might mimic like a PCOS. So for them, the pace of development of symptoms is something that we really need to look for, because you would find the degree of virilization and the hyperandrogenic symptoms would be really at a very faster pace as that in comparison to what you expect in a normal pubertal development, right? And the age can also be a little earlier than the normal age of puberty. So if you have some clinical stigmatas where you find that there is some age inappropriate virilizing features, please think of the tumors as well, the virilizing tumors which could have an adrenal or an ovarian tumor, ovarian origin. And for this, you would like to do a imaging as well as you can do biochemical tests like DHEAs, right? Then there could be some drugs which can have androgen excess, specifically when anti-epileptics, if we talk about valproate, they can also present with features of PCOS like clinical symptoms. Then in our clinical scenario, we have children with a lot of systemic disorders again, right? So systemic disorders will cause some level of hypothalamic dysfunction, and it can lead to a state of functional hypothalamic amenorrhea. So please rule out all the important chronic systemic disorders, which can have some menstrual irregularities also. And the conditions like Cushing's and all, they can also mimic PCOS, but I would say a simple screening test like a overnight dexamethasone suppression test would be good enough for a midnight salivary cortisol level. But don't, I would say, expose all these investigations in all cases, right? So one has to really take a good history examination and then make some differentials before really going on. So unless you have a clinical phenotype, please don't go ahead with these investigations at the outset for all patients. But yes, definitely you should rule out thyroid dysfunction and hyperprolactinemia specifically in all cases before you really make a diagnosis of PCOS. Thank you, sir.
One question about what we are discussing in this slide. about non-classic CAH. So, a question to all the panelists is that in your clinical practice, how often in the workup of PCOS, or maybe just in the workup of hirsutism as such, how frequently you find that the 17-OHP levels are elevated, or there are other features indicative of non-classic CAH?
I would say, sir, it depends upon we obviously don't screen it at the outset for all children with PCOS. If we have clinical features which are suggestive or like virilization acne, but if there is an accelerated bone age and if the clinical features seem to be a little disproportionate to what you are actually looking for, like I've said about if there is presence of clitoromegaly or the amount of pubic hair distribution seems to be more than what you are really looking for, is if you have a girl of say 11 years with a bone age of 16 years, then probably I would like to go in for this kind of a ruling out the presence of CH. But in my clinical practice, something like non-classic CH, which is not very really common, because we did a dissertation last year only about the etiology of the presentations of children who are presenting with acne, and this in fact, out of almost 100 children we screened, we found only one case of non-classic CH.
Yeah, actually,
So,
why I'm asking this question is because it's not uncommon that off and on you get the 17 OHPs and you get a value which is not within the normal range, say in the elevated in the range of 3, 4, maybe 5. So, what is our approach? What should be our approach? Although it's a little going away from, but just a quick question and we'll proceed further.
right. So ideally, what we do is we use the follicular phase 17-hydroxyprogesterone that we do an 8 a.m. level in the follicular phase. And if we have a value in the gray zone, then we go in for the ACTS stimulated test. That is, we use synactin and measure the 17-hydroxyprogesterone level after 60 minutes. And if we have a classical value of 17-hydroxyprogesterone, which goes beyond the range, then we are definitely looking for the non-classic CH. But I would say nowadays we have the benefit of getting a steroid profiling done. So what we prefer to do is we get the complete steroid profile after giving ACTH, and this helps us in clinching a diagnosis of even the 11 beta and the other problems, rather than just picking up 21 hydroxylase. So complete steroid profiling is something that I would advocate more now, since we have the facilities for LCMS in the commercial labs, and that will help us in further clinching the diagnosis and also knowing which kind of an enzyme deficiency we are dealing.
Any comments,
Yeah, Dr. Bhan,
Ganesh?
I do it a little differently. So for those girls that are not coming in with hirsutism, yes, probably I'd take a little similar approach. But those that have a significant hirsutism, which I mean, that's what we are using for the criteria of PCOS, I do tend to rule out non-classical CAH for all of them. So I use the same steroid profiling LCMS-MS assay. It's not very common, but it's also seen that, it could have been easily missed if we didn't get it also. So I do tend to do it, and even this ultimately we do end up doing a stimulated level, because if it has come in that range, we do want to make sure that to get a stimulated 17 OHP to define it as a a non-classical versus a carrier sometimes, like if it's not that high. So but yes, if their degree of presentation of the hirsutism is that much that they may benefit from hydrocortisone versus OCPs, that question also comes into picture, how are they presenting? So then yes, I do tend to do it for most of them.
Yeah. Ganesh, any comment?
So, 2-3 comments. One is that you cannot clinically rule out non-classic CH. It would be important to, wherever possible. Second thing is that just because you have a diagnosis of non-classic CH, the line of treatment in most cases of non-classic CH is similar to polycystic ovary syndrome.
Yeah.
I mean, you are managing that with largely diet, lifestyle, OCPs or spironolactone or these kind of treatments. There are very rare occasions where you have to use, at least in pediatric age group. I'm not talking about, young women having recurrent miscarriages, etc. At least in pediatric age group, use of steroids is a rarity. You asked about experience of what percentage of cases generally would turn out to be having non-classic CAH. I think Dr. Mittal and Dr. Amini had done a study long ago, from All India Institute, and they found a positive ACTH stimulation response in about something like 6 or 7% cases. I think the actual numbers may be a little low, maybe 3-4%. I have come across, let us say, like in the last 10 years, I would say 3 or 4 cases amongst maybe hundreds of cases that we've evaluated. So it is not a very common diagnosis, but it is not something that you can diagnose without. You may decide, because doing a synactin stimulation test is a very difficult task. Obtaining the availability of synactin is a very difficult task. So you may kind of decide to wait and watch for borderline high 17-hydroxyprogesterone values. But for something which is more than 5 or 6 nanogram per ml, I feel that the index of the diagnosis would be more likely.
Yeah.
The guidelines say that if anything more than 2 nanogram per ml, we should do a stimulation test.
Exactly. Actually, that's why, because often while evaluating some of the patients, this question popped up, and since we know that it's a clinical continuum in the presentation of CAH, so with every salt losing child which we see, there has to be maybe 15 to 20 times more simple virilizers counterpart. So that's what I was wondering, that what is the overall approach, and I think
interestingly, we have had 1 or 2 cases of classic CAH, which was not diagnosed, simple virilizing classic CAH, presenting with severe hyperandrogenism and clitoromegaly, and it was a classic CAH, not a non-classic CAH. So a diagnosis of classic CAH often can be missed.
Yeah, we recently had one boy who came with peripheral precocity and everything. And along with that, first time in his life, at the age of 5 years, he went into salt losing crisis. So
we have exceptions.
Yeah, so it's maybe it's not in black and white, it's all shades of gray. Okay, continuing with our questions. Next question is to Dr. Sumit. So we have discussed about number of hormones. So let's hear it from Dr. Sumit, that which all hormones need to be tested in evaluation, because this is one question which I think need to be addressed in a very specific manner. There is always a lot of confusion, what to be done, what not to be done, unnecessary test in these situations, unnecessary burden to the family, and more is a problem, because many a times some of these tests might come out of the range, and then you have to take decisions and counsel the family. So Dr. Sumit, please tell us about that, which all to be done and which all not to be done.
Yes, thank you, Dr. Bhanu. So it's more of a repetition of Dr. Preeti, probably already covered a lot of it. And I would say that history is a very important parameter to outline like what all needs to be done. But we do have to remember that PCOS is a diagnosis of exclusion, and it is very important that we rule out secondary causes before we label somebody as PCOS. So ruling out non-classical CAH is one of the factors that we take into account. So that's why that morning follicular phase 17 OHP that is something that's needed. Again, total testosterone levels and SHBG levels to find out the calculated free testosterone level or the free androgen index level, or even if we're using a basic total testosterone level to find out if this is PCOS. If we find that there are the rapidity of hirsutism is quite significant, so our history is telling us that there may be a risk for androgen producing adrenal tumors. then we should, yes, definitely get a DHEAS level. And similarly, we may have to get an androstenedione level and a pelvic ultrasound to evaluate for ovarian tumors if the rest of them have come back as normal, and we're still not able to figure out, why the hirsutism is that significant and why it's progressing that rapidly. Like Dr. Preeti had mentioned, we do want to rule out hyperprolactinemia and hypothyroidism, especially if they're fitting into the irregular period morphology. And Cushing syndrome, if we have that typical stigmata of Cushing syndrome, whereby they are overweight, there is some violaceous striae that we are seeing. Finally, if once we have considered other factors and once we've ruled out other causes, then we should look at the total testosterone and SHBG levels also. And the cutoff, like Dr. Preeti had mentioned, is more than 55 if we're using the RIA assays.
Yeah.
Yes, and to elaborate on this, a lot of times, the adult counterparts do get an AMH level, and we see a lot of gynecologists ordering an AMH level for even the adolescent age group for people for PCOS. Now, we have seen and we know that in PCOS adult women, the levels are higher. But
Dr. Sumit, there is some problem in your audio, it seems.
Okay. Is it better now?
Yeah, it is better now.
If the signals are weak, then Dr.
So,
Sumit, you
I
can
feel like
switch off your
AMH level usually is not.
Okay, so the summary
Yeah, great
is
idea. I'll do that.
that okay. So we should. So AMH is not recommended, especially for our adolescent PCOS evaluation. Okay. Next question is to Dr. Ganesh. It is about imaging modalities. Although we have already discussed about some of the things like PCO morphology and all, but let us clarify this once and for all. So, what is the status of imaging modalities? Yeah.
So one is the most important lesson is that ultrasound is not recommended for diagnosing polycystic ovary syndrome in adolescents. They say that up to 8 years of gynecological age, which means that up to 8 years post menses, it is not reliable for making a diagnosis. Most of the criteria in adults are based on transvaginal ultrasounds, which is not possible to do in pediatric age group. So imaging is mainly done to rule out differential diagnosis, such as adrenal tumor, ovarian tumor, etc. So the role of imaging in polycystic ovary syndrome is largely to rule out other conditions, not per se diagnosing PCOS.
Yeah. And similarly, any requirement, can you think of any scenario in which neuroimaging can be required?
So some girls present with primary amenorrhea. In primary amenorrhea can be a rare presentation of polycystic ovary syndrome, but anybody who is presenting with primary amenorrhea, we should think of primary ovarian insufficiency or central gonadotrophic hypogonadism as a differential diagnosis. So in those cases, doing a FSH and LH is very important. And if FSH and LH is low, then pituitary and hypothalamus imaging, cellular imaging will be important.
Thank you. Thank you. So next question is about, now we are coming to the management part. And to begin with, Dr. Preeti, please tell us about the lifestyle measures, because we know that even in adult as well as in adolescent PCOS, lifestyle measures are the frontline modality when we talk about the treatment. So what we understand, what are their role, and specifically what all measures are there?
Yes, sir. So if we go on to the management, there are some goals of management, right? So one is to control the symptomatology. That is, we'll talk about the menstrual irregularities. We'll talk about the clinical features, that is the clinical hyperandrogenemia, right? But at the same time, we need to remember that there are some comorbidities and complications that also need to be taken care of, like obesity and its other comorbidities, impaired glucose tolerance, type 2 diabetes, dyslipidemia, which are importantly associated with this PCOS syndrome. And the third important component is the psychological support or the psychological care that we need to provide. And the role of lifestyle interventions is phenomenal in achieving all the three goals, right? So hence is the importance of the lifestyle interventions. And we are all aware that among these lifestyle interventions, we are actually talking about the dietary management, the exercise management, the weight control, weight management, and the psychological care that we require in all children, right? So that is something which we need to keep in mind, because if we look into the pathophysiology of PCOS, we know that hyperandrogenemia and along with that, insulin resistance is something which is one of the important core central driver for PCOS. And this insulin resistance can be taken care of if we start utilizing the lifestyle interventions right from the beginning. So hence is the role of lifestyle interventions in controlling all the metabolic disturbances that happen along with PCOS. They help in the weight management, they help in regularizing the menstrual cycles, they reduce hyperandrogenism and provide an overall help to the overall improvement, the psychological improvement of the child. So if we look into the dietary changes that a child needs to undergo, because usually most of the cases you find that children are actually having obesity, though we also have a lean phenotype for PCOS. Even for them, hyperinsulinemia and insulin resistance is something which is there even in them, right? So dietary changes would involve something like a diet which has a low carbohydrate intake. We emphasize particularly on the intake of whole grains, lean proteins, the healthy fats, that is the omega-3 and the fatty acids, which can be given or provided using nuts and seeds, good fruits and vegetables. These all have a very important role. So a balanced diet needs to be encouraged and started from the outset. Then weight control and weight management is an extremely important component, because it's been seen that if you have a 5 to 10% reduction in body weight, it improves the symptoms significantly, right? It helps in achieving a good hormonal control. A hormonal balance is maintained, the HPA axis dysfunction is reverted to a certain extent, and also helps in controlling the weight, overweight and obesity. That is a driver for other metabolic problems, right? And again, we encourage children to undergo both the aerobic as well as anaerobic exercises, because it helps in improving the insulin sensitivity and also promoting weight loss. Another important thing, which is extremely important, is the importance of good sleep, good amount of fluid intake, and a regularization of the routine. So most of the children with PCOS, they are having problems with their routine. They have increased sedentary lifestyle, they have increased screen time, they have improper sleep hygiene, they don't have a regular routine, and that actually disturbs their hormonal profile. So it's important that we incorporate good stress management techniques, relaxation exercises, because that also helps in building, in providing a good hormonal milieu, and it actually regularizes their cycles also. It decreases their stress and also helps in providing the psychological support that is required, because often these children, they suffer with a lot of other issues like poor self-esteem and stress, anxiety and depression. So all these things have to be taken care also. So if you start incorporating the lifestyle interventions at a very early stage, a lot of complications can be averted. It can be prevented, but at the same time, you also have to remember that it has to be inculcated or started at the level of the family. The entire family has to participate, because if you only target the child, in most of the cases, it becomes a failure. So you have to encourage the lifestyle interventions for the entire family, taking into account the child's routine, the financial aspects, the dietary habits of the family, so that it becomes like a regular thing for them, and it doesn't become like a something which is imposed on these children. So we'll talk about the pharmacological agents, but yes, without lifestyle interventions, it has no meaning, because now we don't call it as PCOS, we actually call it as a reproductive metabolic syndrome. That's a new term which is coming up for PCOS, because we will discuss it in the later slides, that what exactly leads to, what exactly happens if you allow the PCOS like a syndrome to continue. So it has implications, a lot of implications in the later life.
Thank you, Preeti. I think we are overshooting the time assigned to us by Richa. So in the next, we'll have three quick questions now. Three or four, three more quick questions. Dr. Sumit, when, how, and which frontline pharmacological therapies are introduced in the management? So, yeah.
I'll be quick. So yes, like Dr. Preeti mentioned, that diet and lifestyle is the cornerstone and it will normalize insulin resistance. But to really help with the quality of life, and for those that are having like irregular periods, they'll be at risk for endometrial hyperplasia and eventually later on a future risk of endometrial cancer. So OCPs do help with those regularization of these oligoanovulatory cycles. Of course, it helps with hirsutism by reduction in the free testosterone levels when it increases the SHBG, and also because it suppresses the LH drive. So if there are no contraindications, that's the first line to go to. Then there is metformin that can also be given if there is a higher degree of insulin resistance, or if adolescent is pre-diabetic. It also has shown to have a reduction in the ovarian and adrenal androgen production. And of course, it has its own benefits towards weight and cholesterol along with the insulin resistance. And there are some small studies that have shown a comparison between metformin versus OCPs, and they have shown a similar clinical benefit towards hirsutism. So yes, if hirsutism is the primary concern and there is some prediabetes, metformin would be the go-to medication. Then we have anti-androgens or androgen receptor blockade like spironolactone. So if OCPs are contraindicated or they've not been helping for after being used for 6 months, it does help with hirsutism. It's just very important that the family is counseled regarding the risk of teratogenicity. And it has also been shown that if we use OCPs along with spironolactone, there's a significant benefit in the clinical hyperandrogenism.
Thank you, Dr. Smith. What about other therapeutic modalities which can be utilized in this situation? Because cosmetic issues are many a times a major cause of concern. So, Dr. Ganesh, can you just throw some light on that?
I think in terms of androgens, particularly in girls with alopecia, we sometimes use finasteride. Practically, flutamide and cyproteron in the doses that are recommended are not, very rarely used. I have not used them any time. Other option for a localized hirsutism or localized hair growth could be topical eflornithine. But many girls may with acne or hirsutism may need to follow up with dermatologist. And for hirsutism, if that is the only problem, they can also go for only cosmetic measures, which could be temporary measures of hair removal or permanent measures such as laser. Although we say permanent, sometimes if the hormonal imbalance is significant, then there could be recurrence of hirsutism. So sometimes we complement the hormonal therapy along with the laser therapy. These are some of the options for the symptoms of polycystic ovary syndrome. There is a lot of interest in chiroinositol, myoinositol. I personally don't have any experience in using these medications. I don't see much harm using them if somebody is using, but I think it is more used in adult patients, more so by gynecologists than endocrinologists. If there is a massive obesity, if there is significant obesity, then liraglutide can help in weight loss as well as improvement in the symptoms of polycystic ovary syndrome.
You are using liraglutide. You got any opportunity?
I have had about 4 individuals where the weight was more than like 110, 120 kg. As long as they're using it, the results are good.
Okay.
But over a period of time, they seem to kind of get tired of taking the shots every day and they stop it.
Okay. Okay, now that we have discussed about its entire management, so Dr. Preeti, please tell us that what all we expect as an outcome, what is the usual natural course and outcomes with PCOS, which is diagnosed during the adolescence.
Yeah. So PCOS, as I previously also said, it can be considered like a reproductive metabolic syndrome. So if the child or the adolescent continues to have the drivers, the risk factors for PCOS and the lifestyle interventions are really not started, you have a risk of problems coming up later in life. And if we start with the metabolic problems, they are enormous. So if the child is already having the overweight or obesity phenotype, and this is accompanied by problems like impaired glucose tolerance, the child can develop type 2 diabetes, can have dyslipidemias, and develop non-alcoholic fatty liver disease. And now the new term has come up, which is called as the MAFLD, that is metabolic dysfunction associated liver disorder. So these are the important metabolic components that we see in these children. But apart from that, there are problems related with the reproduction also. So often we find that these children have problems becoming pregnant. So they have problems like they have infertility. Then, as Dr. Sumit said, that if we don't really take care of the endometrial hyperplasia, they have a higher risk of developing endometrial carcinoma. And because of all these problems, they suffer with really very poor psychological well-being. They have problems of anxiety, depression. They have very low self-esteem and poor body image issues. So all these things, they actually impact the entire personality of a female. So I would say that what we need to do is to really act very early. So I would just like to highlight on another important point of prevention, that what we can do is to identify the symptomatology early, act early, because if what has been seen nowadays is that if the women of the reproductive age group have all these important risk factors, like what we told about the obesity, the stress, the anxiety, depression, which is also seen like a new teratogen now. Now, this female will actually give rise to a child who is having problems related to the birth weight. So these are the ones who will have IUGR, low birth weight, prematurity. And again, there would be something like a two-hit story starting again, right? So they have the hereditary traits, and later on, if they are really not taken care of well, they can have problems like developing into premature adrenarche and again going on to the cycle of PCOS. So it becomes like a vicious cycle. So this is an opportunity that we need to provide a good amount of preconceptional care that we can provide to the females of reproductive, the adolescent and the reproductive age group, so that this vicious cycle is not repeated, and hence is the role of diet and the lifestyle interventions for these females. And another thing which I just wanted to highlight, that September is the PCOS awareness month also. So Dr. Bhanu, we have actually covered a very important topic in the right month. So this is something
thanks to Richa.
Right. Thanks to Richa and Dr. Bhanu for bringing up this topic for discussion.
Yeah.
Thank you.
So I'll just go through the key summary points, which I think we all should take home. So diagnosis of PCOS is challenging in adolescents, and because there are a number of overlaps with the physiological features seen in adolescents, the primary focus has to be on menstrual irregularities and hyperandrogenism, both clinical and biochemical. There are many other associations, but they are not really required for the diagnostic evaluation. Maybe to establish the association, it may be required. There are few tests which are very commonly advised in adults, but they are not recommended for adolescents. For example, ultrasound for PCO morphology, AMH levels, and to establish the insulin resistance, like fasting insulin and HOMA-IR calculations and all. It is important to rule out common conditions which may mimic PCOS, especially thyroid and prolactin. Dietary and lifestyle measures remain the frontline measures for the management of this condition, and it is supported by some of the pharmacotherapy, primarily aiming towards menstrual irregularities, hyperandrogenism, metabolic dysregulation, as well as cosmetic issues. And with optimal management, one can ensure that even despite the diagnosis of PCOS in adolescents, the entry to an adulthood for the girl can be ensured. I would thank all the panelists for such a great discussion and clarifying much issues about this situation, which generally pediatricians are a little scared of. Over to our chairperson.
Thank you, Dr. Bhanu.
Thank you, all the panelists. Thank you, Dr. Bhanu, Dr. Sumit, Dr. Priti, and Dr. Ganesh for a wonderful discussion. And from general discussion, this is quite clear that this is basically a disease where you require a good teamwork between the pediatricians and pediatric endocrinologists. For pediatrician to diagnose the disease, to basically have a suspicion and confirm the diagnosis with pediatric endocrinologist, and follow up also in general OPD for general pediatric diseases, then the pediatrician can reinsure the lifestyle management. Dr. Bhanu, can you tell me what is the general prognosis? Does the disease remain lifelong or they subside? And in how many percentage of patients you require drugs? If response comes in how many months? Like?
Yeah, there are a number of factors actually which are associated, as some of them are discussed also here. If there is a genetic propensity, like it's running in families, and there is a history that other members in the family, they had a condition which was difficult to manage even during adulthood. Similarly, association of obesity. So the girls who have a tendency for obesity may not show very good response to even the pharmacotherapy if the diet and lifestyle measures may not be taken care well of. However, since the primary focus remains on the diet and physical activity, lifestyle measures, once these are ensured, the positive outcomes are very much expected. And say more than 50% of the girls with proper compliance to the management, you can expect good results, say within 1 year or so.
Sorry to disturb, sir. In between, before going on to the further questions, I would like to introduce Dr. Manjusha also. She's an obstetrician, and we would like to hear her perspective. She also was chairing the session. She was absent in between the meeting. Dr. Manjusha, I would like to hear, because obstetricians also play an important part during the management. So what is your experience and please. Is she here? I think this.
She is there. Dr. Manjusha?
Ask to unmute.
Anji.
Yeah. So, ma'am, your perspective for the PCOS, what's your experience for the PCOS? Because as the kids grow up, the adolescent, you are the people who are handling them. And
very rightly said, Richa, as Dr. Bhanu also said, that pediatricians do not want to see the patients with menstrual irregularities. But I feel patient also doesn't want to visit pediatrician for their menstrual irregularities. Most of the mothers who are visiting their gynaes, they will bring their daughters to that gynae only. And as a gynecologist, we feel nowadays they see lots of things on online, and then they come to us with the ultrasound report. And more than 70% of the reports will write down PCOD. Now, the one criteria, as per we all know, X-ray is not the criteria for PCOD. तो आप उनको ये समझाना कि ये पीसीओडी नहीं है और प्यूबर्टी मेनोरेजिया चल रहा है या प्यूबर्टी इरेगुलरिटीज चल रही है which will settle down with time is also more important. Like PCO is not the primary thing, so we should always see for the HPO axis का immaturity also. और हार्मोन्स देने से उनकी हाइट में डिफरेंस आएगा. बहुत सारे लोग 10-11 इयर्स पे रिजेस्ट्रोन मैप्रेट शुरू कर देते हैं, वो भी रिस्ट्रिक्ट करना है. सो काउंसलिंग एंड काउंसलिंग इज द ओनली थिंग विच इज नीडेड. मदर की भी काउंसलिंग, क्योंकि मदर्स के पास भी टाइम नहीं है अपनी गर्ल्स को ध्यान देने का, तो दे ऑल्सो वांट फाइनल वन लाइन सोल्यूशन. एंड चिल्ड्रन तो ईटिंग और वो सब अभी आपने डिस्कस ही किया दैट मोस्ट ऑफ देम हैव दीज काइंड ऑफ प्रॉब्लम्स. So practically we see lots of PCOD, and thin PCOS patients are more nowadays. Earlier we were seeing only obese PCOS, but in our practice we see more of the thin PCOS patient, and we do not have many drugs for them. So practically whatever deliberated by our learned panelists, they also will help us in treating our patient. Thank you so much for such a nice panel.
Thank you, Dr. Manjusha.
There are few questions in the chat box, Dr. Bhanu.
I think we can take them on, we can answer them on the chat itself, because we have already overshot significantly, isn't it?
Okay.
Okay.
Dr. Soha, yeah. Please just answer
Yeah,
anybody of you can answer this
Sure.
question. Just so after this, we will go on to our next session. And thank you to the Dr. Bhanu, the chairpersons, Dr. Sumit, Dr. Ganesh, Dr. Preeti. It is a very broad topic to be covered in a half an hour. But still, I think we have covered most of the topics and most of the points, and we are better learned now. So coming on to our next topic, we have obesity and metabolic syndrome. So for this, I like to invite our chairpersons. Just a minute. For chairpersons, we have Dr. Manjusha will be chairing this session. She is lead consultant at CK Birla Punjabi Bagh. She is holding positions in DGFs and IMA zone in the Rohini zone. Then we have Dr. Pooja Jain. She is also a gynecologist practicing in Rohini. But she's associated with Fortis Hospital, and she is also the Joint Secretary of Delhi Gynecological Forum. Welcome, Dr. Pooja. And so over to you for this, Dr. Pooja and Dr. Manjusha.
Dr. Pooja is taking?
Dr. Pooja, is she there?
Yeah, I'm there, but Dr. Manjusha, you take.
Speaker introduction you do because I was correct.
I have shared with you, Dr. Pooja. आप बता. You can.
No, you have shared with me on WhatsApp.
Yeah.
Just.
रिचा आप इंट्रोड्यूस कर दो. We are already
I will.
late. आप कर दो इंट्रोड्यूस.
You want me
For
to
the
share?
next session, I would like to invite Dr. Divya. Yeah, just sorry. She's my she's a known pediatric endocrinologist. She's from Chennai. So she has done her MD Pediatrics from Safdarjung Hospital. She was my colleague there. Then she has done a fellowship in pediatric endocrinology from Manipal Hospital, Bangalore, and also her fellowships. So over to you, Divya. Thank you for accepting the invitation, and the floor is yours.
Welcome, Dr. Divya.
Thank you, everyone for the. Am I audible?
Yeah.
Yes, you're audible.
Right. So at the outset, I would like to thank Richa ma'am and Bhanu sir, with whom I had a wonderful experience during my post-graduation at Safdarjung. So thanks for having me here. So I'm just my slide is visible.
Yes, it is visible.
Yes, it is.
It's
okay. So today I'll be discussing on obesity and metabolic syndrome. The topic given is like genetics loads again, but
Ma'am, you are on mute.
I think it
Mr.
just.
Zulu, can you unmute? Can you mute everyone? There is some voice coming in between.
Yes, I'll just check, ma'am. I'll just mute the people who is voice just आ रहा है वो mute कर देता हूँ. So everybody is mute apart from Dr. Divya
Okay.
and Dr. Richa. Okay.
Thank you. So, so moving on to the topic. So I'll be talking about, introduction about the childhood obesity, the causes and the risk factors associated with it, followed by an approach and management of childhood obesity. So in other words, I'll be talking about how the gun is loaded, like that is the genetics perspective of it. And then I'll be discussing about what happens if the trigger is pulled and how to avoid pulling the trigger. Okay, so that to simplify my topic here. So why is childhood obesity worrisome? So it poses a significant emotional and psychological burden to the child. There is so much of bullying that happens among schools. I mean, I hope it is wide across North and as well as South. And they are more likely to become an obese adult, and they are at higher risk of non-communicable diseases. And being obese itself reduces lifespan by about 5 years, and it also increases the healthcare expenditure. We will be discussing this about in detail in the next few slides. So coming to definition of obesity, under 5 years, we will be using WHO charts. The chart that I want to highlight here is weight for length or weight for height charts. So weight for height that is falling between second and third standard deviation on the higher side. Okay, so it is overweight, and any weight for height that is falling beyond the third standard deviation, it's called as obesity. And for children aged between 5 to 18 years of age, we are using IAP charts. And as you can see, the IAP charts, the BMI charts are color coded. So a BMI of 23 adult equivalent is considered as overweight, and a BMI of 27 adult equivalent is considered as obesity. Why these cutoffs are being used? Because we are thin, but we are at a higher risk of metabolic syndrome, even at a lower BMI compared to our Western counterparts. That is why we have been using that. And the BMI percentiles are different for boys and girls for definitions of overweight and obesity. So moving on to the recent update in the IAP obesity guidelines. So they classify severe obesity into class 2 and class 3 obesity. So a BMI that is more than 120 to 140% of the 95th percentile is called as class 2 obesity. And class 3 obesity is more than 140% percentage of the 95th percentile based on the age and gender. Now, as I said, like we are much thinner compared to our Western counterparts, but we do have more adiposity compared to them. Okay, so we may be having a normal BMI, but we may be having more visceral adiposity. Hence, there may be better measures of adiposity than using a BMI like waist circumference. It may be prudent to use more than 70th percentile line as an indicator for increased waist circumference for Indian population. Some studies have used wrist circumference too. And obviously one can use DEXA scan for fat mass measurements and bioelectric impedance analysis. Now, so where do we stand according to World Obesity Federation? Our country stands at 174th rank worldwide, and the prevalence of obesity is about 3.07%. This is second highest globally, only next to China. And NFHS 5 have mentioned that under 5 overweight is at the rate of 3.4%, which is higher than the previous NFHS 4, which is 2.1%. The number may think like, only 1% increase. However, if you look at the population number, it is relatively more. And 10 to 19 years of age, 5% of the children are overweight or obese, and there is an increased proportion of overweight among rural population. And this is going to create an economic impact, which may cost about 2.5% of GDP. Imagine obesity alone costing healthcare expenditure of about 2.5% of GDP. So I don't think like 60% of the healthcare expenditure is from out-of-pocket expenditure in our country. So then you imagine I don't think like we are still ready for such a kind of health expenditure in any near future. So moving on to etiology of childhood obesity, it is broadly classified into 4. The most common one, the exogenous obesity, is basically due to insulin dynamic disorders or insulin resistance. And there is the other forms of insulin dynamic disorders like hypothalamic obesity, leptin resistance, and other forms. And monogenic and syndromic disorders are usually due to genetic mutations. Monogenic, it is either leptin, preopium melanocortin receptor mutations, or melanocortin receptor mutations. And syndromic disorders, some examples will be like Prader-Willi or Broad-Edwided syndrome. And then we have the classical endocrine disorders that can cause obesity like hypothyroidism, Cushing syndrome, growth hormone deficiency, and pseudohypoparathyroidism. Now, in short, to highlight about the monogenic or the syndromic obesities, so we have the 2 important nuclei, paraventricular nuclei and the arcuate nuclei in the hypothalamus, which are regulating the appetite and the satiety. So leptin acts in the arcuate receptor, and then it activates the POMC, and then it further acts on the melanocortin receptor, and this pathway of satiety gets over. Okay, so any medications that are going to act on the melanocortin receptor or at the POMC receptor level or at the leptin receptor level is going to have a significant impact in the treatment of these monogenic or syndromic obesities. So to shortly explain, extreme early onset obesity, like, onset of obesity less than 5 years of age, or there is a family history of extreme obesity, one has to think of monogenic or syndromic forms of obesity, and they are very rare. They constitute about 7% of pediatric obesity, and this is where we recommend genetic testing. And one can, broadly classify it into obesity with the developmental delay, like Prader-Willi, Albright hereditary orthodystrophy, Bardet-Biedl syndrome, and there is obesity syndrome without developmental delay, like mutations in the leptin receptor or the melanocortin receptor pathway, etc. Moving on to polygenic obesity, which is more common, and it is also called as the insulin dynamic disorders. From the registry of Dutch famine, and as well as the Hertfordshire registry in the UK, I mean, these registries were taken during the time of famine created by the Second World War. And the children who were born around that time were followed up. And when they have become, old enough, like 50, 60 years of age, they were analyzed for metabolic syndrome and, diabetes mellitus. And as you can see in the graph that, children who were relatively born low birth weight were at a higher risk, or were tend to have more impaired glucose tolerance and more incidence of syndrome X compared to children who were born in the normal weight or more weight. So over the years, as you can see, there are multiple genes that can, act in a smaller proportion, multiple genes in smaller proportions, causing some DNA modifications, okay, that can lead to polygenic obesity. So the modifications that can happen usually is the DNA methylation, histone modifications, and activation of non-coding RNAs. So what happens is when a gene gets methylated, it is getting silenced. So it won't get activated in the body. So that is how it is. So there are so many genes that are involved. Like, if you are sleep deprived, there are particular set of genes that can get methylated. So that's how it goes on and on. And moving on to risk factors of obesity. So both SGA babies and as well as LGA babies are at higher risk of having childhood obesity. As you can see in the graph that is given, both the extent are at having higher risk of, being an adult with a higher BMI. So, and there is also, children born to diabetic mothers, prematurity, mothers with preeclampsia and maternal undernutrition, they are also at risk of ending up with the childhood obesity. And SGA children in the study done by our Australian colleagues have observed that they have lower insulin sensitivity, which in other words means that they are insulin resistant. And the same thing applies to premature born children too. So they are also at a higher risk of insulin resistant. So what happens to our, Indian children? So if you take this study by Yajnik et al., you can see that, the number of newly diagnosed type 2 diabetes compared, Indians comparing the UK whites. So there is at least, Indians have been diagnosed with diabetes at least 10 years younger. They are much thinner, but they tend to have more fat mass and, 1.5 times higher insulin resistance. And you all must be aware of this picture, the YY paradox. So the person on the left is Dr. Yudkin, and the person on the right is Dr. Yajnik. As you can see that they both have the same BMI, but their DEXA picture is showing otherwise around. As you can see that, the Dr. Yudkin looks more heftier than Dr. Yajnik, but however, the body fat percentage is different. Okay, so even though Dr. Yajnik looks much thinner, his body fat percentage is like 21.2%. So this led to the hypothesis of thin fat Indian phenotype. And if you look at the registry of Pune, where they have followed up SGA children over a period of 8 years, and they have observed that, at 8 years of age, there is a significant insulin resistance among children who were born underweight. And also in the Mysore Parthenon study, where they have followed up children born to diabetic mothers over a period of 20 years, have shown that these children are at higher risk of dysglycemia and higher risk of having a high diastolic BP and higher total cholesterol levels. And this has led to the hypothesis of developmental origins of health and disease, where the dual teratogenesis process. So the child is born in an undernutrition condition, exposed to urbanization, and leading to overnutrition and its associated complications. So the other risk factors include weight gain in infancy and childhood, which can lead to adiposity rebound, and they are at 1.3 times a higher risk of becoming an obese child. Infant nutrition, 4.5% in non-breastfed children and 2.8% in breastfed children. Early onset of puberty, because they are going to end up growing very early. So that may be the reason. And adolescent weight gain, that depends on the fat distribution, and along with, that may lead to comorbidities. And they are at 17.5 times at a higher risk of ending up to be an obese adult. And then we have the genetic and hormonal issues, drugs causing obesity, physical disability or inactivity. So that is something. If you look at the India report card for physical activity for children and adolescents, India stands somewhere between C- to D grade. And even in the recent report card, there were multiple incomplete data, and the gradings is much better compared to 2016. But still, a lot more need to be done, from our side, from the government side, regarding improving physical activity among our children. So how to approach a child with obesity? So first thing is to, appropriate identification of obesity, and, identify correctly which is pathological obesity, and also evaluate for comorbidities. So this is our first case, 8-year-old female child who came for general checkup. The child always been a healthy child, no other symptoms. As you can see, her height is within the normal range, maybe a little taller than the parents. And however, the more pathologic thing is that her weight is beyond the percentile lines. Okay, so she is having what is called as obesity, nutritional, but here I'm saying it due to nutritional causes, basically because her height is preserved. So moving on to next case. So here we have a similar child. This child is also obese, But what is more contrasting here is that this child is short for the population. So this is the picture of the child. So I was called in to the management of the child because he was having hyperglycemia, admitted for a different reason, but upon a routine investigation found to have hyperglycemia. And as you can see, he's having these almond-shaped eyes, smaller hands and feet, and proven to be Prader-Willi syndrome. And this is another example of retinitis pigmentosa, hypogonadism polydactyly, LMBB syndrome. And short fourth metacarpals and metatarsals you can see in pseudo-hypoparathyroidism with the mental retardation that can be there. And this is another child like, with obesity and as well as short stature. Of course, the picture is diagnostic. So this is a child with Cushing syndrome. And so these are some examples for pathological obesity, which will make you think in terms of like, this child needs further evaluation and intensive management. Okay. So this is another child, drug-induced obesity. She was a case of SLE and was on steroids for quite a long time. And to compare nutritional and as well as pathological obesity, as you can see, like nutritional, the height will not be compromised, whereas in the pathological obesity, the height will be short. So moving on to evaluation of obesity, a thorough history and a physical examination, including an anthropometry. I would suggest all of us to use waist circumference measurement. So IDF criteria says more than 90th percentile, but it may be important to use our Indian cutoff, which is the 70th percentile. And a thorough examination for any dysmorphism, pubertal assessment, skins and joints, and extraocular movements. Comorbidity screening, I would say all obese children more than 10 years of age, it is a must to do. Obese children with any of the risk factors that I have mentioned previously, or overweight children with risk factors or a positive family history or an associated complications or with the increased waist circumference, then preferable to do comorbidity screening. However, don't do a routine, like all obese children like that, don't do a routine evaluation for genetic or endocrine causes. So this is acanthosis nigricans with extensive striae. And this is another complication which may signify insulin resistance, presence of skin tags. And this is gynaecomastia. So there are multiple systems that can get affected with obesity. So the least that is, give importance is the mental health and the musculoskeletal health, and as well as obstructive sleep apnea. So I think, rest of the things, this side or that side, the child will get evaluated. But these things, I believe one has to concentrate. So comorbidity screening, I think for want of time, I will skip, but one has to evaluate for dysglycemia, fasting, and then OGTT sample is a must. And, one can also do a lipid profile and do dyslipidemia screening. And hypertension at every clinic visit is a must. And evaluation of LFT, so metabolic dysfunction associated steatotic liver disease. So ALT more than 25%, 25 in boys and 22 in girls signify non-alcoholic steatohepatitis. And metabolic syndrome, it's better to use IDF criteria. So the main criteria is the waist circumference and also presence of 2 or more categories, like, either the presence of triglyceridemia or a low HDL, or presence of hypertension or a blood sugar that is more than 100 indicates metabolic syndrome. PCOS in selected cases, and then in selected cases, again, you can evaluate for obstructive sleep apnea or get a psychiatric assessment if you think the child has behavioral issues. Moving on to management of obesity, the general guidelines is, lifestyle modifications. Basically, it is dietary, physical activity, and behavioral, and it has to be intensive, age-appropriate, culturally sensitive, and family-centered. Okay. So one cannot say just lose 2-3 kgs, you will be all right. So it cannot be like that. Okay. Even if you want the child to lose 2-3 kgs, you set up some age-appropriate goals. That is culturally accepted. See, if you eat, some patients will ask, if I eat bread, will I lose weight? If I eat oats, will I lose weight? Okay, so you can use an ethnically appropriate food, but still you can lose weight. And it also has to be, family centered. Both parents might be working, and they will be reaching at odd times. And for physical activity, if someone has to take the child to somewhere, it may not be possible. So again, like family centered approach is needed. So 2 to 7 years of age, we go for weight maintenance, and more than 7 years of age, it is weight loss followed by weight maintenance. So these are common guidelines. So decreased consumption of fast foods or processed foods, decreased consumption of table sugar, and elimination of the sodas, sugar sweetened beverages, and the consumption of whole fruit rather than fruit juices, and improved knowledge about nutritional labeling. I would like to show a picture here. So this is the top picture is in the US, where you can see that the nutrition front of the food labeling. So this mentions that this particular package provides 200 kilocalories if it is consumed that entire package. Okay, whereas in India it is given as this is a family pack of about 130 grams pack, but it is mentioned here as 85. If someone doesn't see this small letter that is written over there, per 16 grams, so okay, right? One will think this 130 gram is going to provide only 85 calories. So a person, even though has some knowledge about nutritional food labeling, have to do some mental maths before buying something. Okay, so this is the state at which we are in. So we are doing something, but that is not up to the mark. And also portion control education. So see, even in the best of the performing states in our country, if you take the plate size has increased over several years. Okay, so the recent plate that we have been using in our family will be, the smallest size will be something like 25 centimeters. The diameter will be 25 centimeters. So I think, it may be better if we, shift on to 11-inch plate or a 10-inch plate or so. And also you can, the 90s or the 90s kids or so, we will remember the popcorn packet that we used to buy when we go to theater and the popcorn packet that we are buying nowadays. Okay, so that's the, difference of portions. The huge portion has become a norm nowadays. So that again, I think like we have to go back to the older days. And then reduced saturated dietary fat intake and intake of dietary fiber, fruits and vegetables, rather than grazing over, so many times. It may be, you can allot some time, some regular meals, rather than grazing over some times, and recognizing eating cues in the child, like for example boredom. Okay, so make sure that the eating cue is not there in the child. Okay, right? So the child is occupied with something else. Okay, so by then, like that hypophagia, you are asking for more food will be reduced further. And this is an example of, this is for an adult plate. The National Institute of Nutrition is recommending this kind of a my plate concept for an adult. Maybe we can use this, the same plate size, 25 centimeter plate or less than that, and use the same portion size, like, half of it will be fiber, and, 1/4 will be carbs, and the rest will be proteins and fats. I think that will be a good option if we start counseling that way. And activities guidelines. So the recommended guideline is 60 minutes per day of moderate to vigorous activity. But most of our kids, in my experience, like, they are not at all active. And, it is always better to start with the lowest possible time, maybe 15 minutes. And then, like, over a week time or so, gradually increase it to 60 minutes as a goal. And limit the non-academic screen time to 1 to 2 hours per day, and decrease other sedentary behaviors such as digital activities, and evaluate for psychosocial comorbidities if you suspect so. So to simplify, as given in our IEP protocol, like, eat 5 portions of vegetables and fruit, reduce the screen time to 2 hours per day, no more than 2 hours per day, and play at least for 1 hour a day. and reduce the or limit the intake of the sugar sweetened beverages. So moving on to pharmacotherapy. So it has to be given only in adolescents, and you have to make sure that the maximum effort has been put on lifestyle modifications. Till then, the child was not able to lose weight, and also one can use class 2 obesity with the comorbidities, and also in children with class 3 obesity. Orlistat has been approved, but it has a significant GI adverse effects, and GLP-1 analogs like liraglutide, semaglutide have been tried. Semaglutide has been recently approved for usage in children about 12 years. And there is this combination of phentermine and topiramate extended release tablets. Again, this combination is not available in India, but this have been again FDA approved for children about 12 years of age. And metformin if the child has glucose intolerance. Moving to bariatric surgery, again, as I said, the child has to be an adolescent, should have completed puberty, should have tried lifestyle modification for at least 6 months, but it failed. And again, like you tried pharmacotherapy and again failed. And also the child has a class 2 or class 3 obesity with the comorbidities, then you can go for bariatric surgery in an experienced centers. So this is sample management plan for childhood obesity. So whatever I have discussed so far is called as prevention plus. Continue this for 6 months. And if the child loses weight, then continue it. And if there is no response and there is comorbidities, then it has to be more intensified. This is where a personalized trainer, personalized dietitian comes. And if there is weight loss, continue with the structured weight management. There is no response, then we have to initiate comprehensive multidisciplinary intervention where multiple visits to physician and as well as the personal trainer and as well as dietitian is required. And if still there is no response, then it requires tertiary care intervention along with pharmacotherapy or bariatric surgery. So to conclude, childhood obesity prevention is the only solution. And as doctors, we can only focus on the the child and the family. However, there are a lot more things like the school, where I believe some schools are selling junk foods like chips and all those things in their canteen. So they have no mandatory standards for food kept in these schools, and also community. See, if the child needs to be taken for a walk, there has to be at least a park in the surrounding. So, that is where the community stands. And also the regional strategies and, commercial practices like food labeling. And also there is national and global support, policies and that are made into legislations. See, at present, there is not much support in order to create a fiscal policy on health food or a ban on junk foods and all those things. So I think that is more needed. So the family and the child is lower down the chain actually. So the key messages, so there is an alarming increase of obesity in children, and this is an international problem. Exogenous obesity, which has a polygenic inheritance, and prevention is the only reliable solution. It should start from preconception and should continue up to post-conceptional feeding, including the feeding and intensive lifestyle at several levels from child to nation. And, even you are the gun here actually. So even if the genetics have loaded the gun, it is up to you. The gun only has to decide whether to pull the trigger or not. Okay, so that is where the role of lifestyle. So not pulling the trigger, you have a healthy lifestyle. So go for help like pharmacotherapy or bariatric surgery only in adolescents with class 2 or class 3 obesity, and make sure that they have completed their pubertal growth spurt too. So thank you for your patient listening. I'll just stop here. Yeah.
Dr. Divya, I have got one question.
Yes.
What is the recommendation of use of alone metformin in exogenous obesity?
Sir, only in cases where you have glucose intolerance, sir, impaired fasting glucose or an impaired glucose tolerance, only in those cases you can give, sir. Otherwise, in general, for obesity, if you give, I
What
don't
should
think.
be the insulin level, ma'am? Fasting insulin level.
So fasting insulin level depends on the age and the pubertal status of the child. So so if the child is pre-pubertal, it is usually less of about 15 or so, and if the child is in the puberty, the level can go up to 30, and after that it falls down a bit, and post-pubertal. So mostly I consider I interpret insulin levels based on the pubertal status of the child.
Thank you.
Thank you, sir.
And what drugs you recommend for obesity normally? GLP inhibitors? Do you give some insight on the use of oral GLP inhibitor? What is your
Sir,
experience?
in my experience, the GLP-1 agonist that I have used is for an early onset obesity child where the hyperphagia was so extensive and the child was weighing about 100 kgs. And with adequate dosage of GLP, liraglutide, the child was able to have some control over the hyperphagia. So that is the one, that is like 1 or 2 patients that I have tried liraglutide. But rest of the thing, I think, as I said, it is only lifestyle. So even if you have a genetic mutation, getting these drugs, like, apparently I believe semaglutide is giving very good results in the Western population for obesity, but I don't think it is available in India. So, and even if it comes to India, it is going to be very costly. So till then,
Liraglutide is available.
Yes, sir.
Liraglutide is available. Oral is available.
Liraglutide injection is also available, sir. I have tried it for some of my patients, and you need to keep increasing the dosage. And it works only if it is if the person has hyperphagia.
Okay.
Yes, sir.
Thank
you. Dr. Divya?
Yes, sir.
These days, physicians are using liraglutide a lot in young adults with obesity and metabolic syndrome. And since we pediatricians are also facing the challenge of obesity in pubertal and post-pubertal age, what should be the guidelines for the pediatrician to use liraglutide in their chamber practice?
I don't think one has to commonly prescribe liraglutide for childhood obesity. And you think if it is exogenous, I don't think it has to be given at all. So first thing is preference to lifestyle modification. So so I believe that, Richa ma'am, you want to add up anything? I don't think one has to give liraglutide for exogenous obesity, sir.
Yeah, I agree with you, Divya. Actually, nowadays patients come with knowledge from the net, like Instagram. They are showing, but actually, if we go by the guidelines, there are no indications of starting as such.
Yes.
So I think we can take few questions in the chat box. Divya, you can remain in the, if there is any questions, any closing remarks from Dr. Pooja, and then we go on to the next session.
Dr. Divya, it was a very, very nice and informative session, especially the colorful plates that you have shown for size and portion control. It was very, very informative, and thank you for such a lovely talk.
Thank you, ma'am. Thank you. So thank you, ma'am, for having me here. Thank you, Richa, ma'am. Thank you, Banu, sir. Yeah.
Thank you, Divya. So we move on to the next session. That's the last session. For that, I invite, we have chairpersons. I will invite my chairpersons, Dr. Shekhar and Dr. Vipin. Just Dr. Shekhar is the consultant pediatrics at Jaipur Golden Hospital. And we have Dr. Vipin Vash. He is the consultant pediatrics at Dehradun. He's has his own hospital at Dehradun. So welcome, chairpersons.
And thank you, Dr.
Thank
Richa,
you.
and I congratulate Dr. Richa and Dr. Bhanu for such a nice online Endocon point zero,
Thank you.
4.0, and it's very helpful for us because we are sitting at our home, comfort of our home, and getting so much knowledge from across India. And the previous talks which we have listened were very inciting, and welcome everybody. And the session would be moderated by Dr. Richa herself, and she is a very great friend of ours, and her qualifications are MBBS, MD, DNB, and she is MRCP UK, Diploma in Endocrinology, APPS Fellow, Finance Secretary of North Delhi IIP in 2023, Executive Board Member of North Delhi IIP 2022. She's also in the editorial board of Cape News 2023, Faculty of Ideal Type 1 Diabetic Course, Organizing Secretary for ENDOCON in 2018-2021, and consultant in various hospitals of North India, North Delhi, like Fortis Hospital, Shalimar Bagh, Jaipur Golden Hospital, Saroj, and Rajiv Gandhi Cancer Institute. Over to you, ma'am. Thank you.
Yeah, thank you. Thank you, Dr. Shekhar. Thank you, Dr. Vipin. So,
Yeah, thank you, ma'am. Thank you. Welcome for the talk. Thank you very much.
thank you.
Thank
So for the next session, the topic is delayed puberty. So after we have discussed obesity related things, PCOS, gynecomastia, now we come to the next important topic in adolescence, that is delayed puberty. So this is also a condition that we encounter in it is encountered by multiple people, either the pediatricians or the gynecologists or the physicians. So we will like to discuss this, for which we have three eminent panelists. Dr. Mahesh Maheshwari, he is the Professor Pediatrics in charge Pediatric Endocrinology Division at All India Institute of Medical Sciences, AIIMS, Bhopal. Then we have Dr. Ashima Dabas. She is also the Associate Professor, Department of Pediatrics at Maulana Azad Medical College. And she is a Clinical Fellow of European Society of Pediatric Endocrinology, and she has a lot of research papers to her credit. And then we have Dr. Medha. She is also the Associate Professor at Chacha Nehru Hospital. Welcome, all of you. So we start with the topic of delayed puberty. So delayed puberty, first the definition, it is a lack of the development of any secondary sexual characters for boys. It's especially the testicular volume by age of 14 years in boys. It is considered to be 2 to 2.5 SD later than the population mean. And if we say for the definition in girls, there is no breast development by 13 years, no menarche by 16 years, and there is a time lapse of more than 5 years between the start of breast development and the first menstrual period. So when we talk, first we will take the few cases about the delayed puberty in girls. When we talk about delayed puberty in girls, I must say that the constitutional delay is the most common cause, but not as common as in boys. And the second, it is usually what we see in the constitutional delay. The girl is not very tall also. There will be no pubic hairs, and she will be generalized decreased in all the spheres. While when we consider the pathological causes, it could be like the pathology is at the ovarian level, or it is at the pituitary level. So if it is at the ovarian level, we see the hypergonadotropic hypogonadism. Or if it is at the pituitary level, it could be hypogonadotropic hypogonadism. So hypergonadotropic hypogonadism means the ovary is damaged. It could be either because of some radiotherapy, or it could be some congenital illness, or it could be some chemotherapy, or the child has received any malignancy. Or if we talk about hypogonadotropic, when the insult is at the pituitary, in this we see functional is seen in 20% of the cases, while permanent is seen in 20% of the cases. So permanent means there is a CNS insult, or there has received intracranial radiotherapy, or there is some genetic issue in the developmental of the pituitary gland. When we talk about functional, it includes that they are reversible. It is transient. It could be because of malnutrition. It could be because of celiac disease, hypothyroidism, or anorexia. So we see, if we take the total number of cases that we see in the delayed puberty, 35% are around physiological. 25% is hypergonadotropic hypogonadism, meaning the insult is at the ovarian level. 20% is permanent and hypogonadotropic hypogonadism, and 20% is functional hypogonadism. So with this background, we will start with our case discussion. So this is a girl, 15-year-old girl presenting with delayed puberty. She has a shield-shaped chest. There is a webbing of the neck, and she has short stature. So, Dr. Medha, so what next and what investigations we need to do in this child?
Thank you, Dr. Richa. We'll go ahead with the evaluation. As you described that the child has not attained thelarchy by the age of 13 years, she is a case of delayed puberty. So we would take a careful history and to assess for any underlying causes such as adequacy of nutrition, any underlying chronic illness, or any features of hypothyroidism. We would also ask the mother regarding her time of pubertal onset, as it has direct relation with the timing of onset in the child. Going ahead with examination, we would take a careful anthropometry, looking at the height, especially because it may be correlated with the stage of puberty. Phenotypic features, as you described, shield chest and webbing of neck would suggest Turner syndrome. But we would go ahead and see for other features as well that may be associated. For delayed puberty, the investigations we would like to undertake are the level of gonadotropins, LH, FSH, and estradiol, going for an ultrasound pelvis to see the Mullerian structures, an X-ray left hand with wrist to see for the bone age. Suspecting a case of Turner syndrome, we would ask for a karyotype, which would see at least 30 metaphases.
Yeah. So, yeah, you can go ahead.
As you said, in this case, we found that the LH-FSH were high and the estradiol was undetectable. So it was a case of increased gonadotropins, this decreased estradiol. So it was hypergonadotropic hypogonadism, which is again corroborating with our suspicion of Turner syndrome. Yes, we would have some differentials for this condition also, which could be pseudo-hypoparathyroidism or delayed puberty due to autoimmune etiology.
So by this, we see that most important is a detailed history and physical examination. In this, we were able to clinch the diagnosis mainly on the basis of the physical examination, and that was confirmed by our investigations. So if, as we have seen that it is Turner syndrome, what are the other comorbidities that are expected in this case, and how is the long-term prognosis of this Turner's?
Yeah. So short stature is an almost essential feature of Turner syndrome, and the comorbidities expected would be most importantly to look for cardiac comorbidities such as coarctation of aorta and hypertension. We should screen for autoimmune conditions such as hypothyroidism and celiac disease. Assess for hearing loss. Look for learning disabilities, any renal anomalies. Deranged liver function test might be there. Screen for ocular abnormalities such as strabismus, hypertelorism, or color blindness, and assess for insulin resistance. So for all these conditions, we can take up appropriate tests. Like for cardiac, we can do an echocardiogram, looking for TPO antibodies and TTG, assessing hearing loss, and an ultrasound for the kidneys. Long-term prognosis suggests an increased mortality up to 3 times, with the prime cause being aortic aneurysm.
So the clear message is that when we are taking a case of a Turner syndrome, it's not only simply a simple case, it is a multi-system disease, and we have to take care of everything. So how we go about with the treatment?
So it is a multidisciplinary treatment, taking all specialists in our team. Of course, the endocrinologist would be the prime guiding the entire team, the cardiac management, if there are cardiac comorbidities, and to screen for them. ENT/eye specialists, assess for speech, and you involve the speech therapist, mental health experts, and renal and gastro experts as required. We would, yes, Dr. Richa, can you move next? We would also need experts for genetic counseling, dermatology, orthopedic experts, nutrition, and would also require fertility assessment later for oocyte preservation. We would start after a karyotype, and the management would include starting growth hormone for the height, starting as early as possible from age 2 years. The results are better. A high dose is required at 45 microgram per kg per day, and keeping the IGF-1 at the higher end at +3 STS. We would also need to start pubertal induction at about 11 to 12 years, start low-dose estrogen replacement, and gradually increase over the following 2 years. We may use transdermal patches or oral ethinyl estradiol, add progesterone later after 18 to 24 months. We should avoid drugs that may prolong the QT interval, such as azithromycin. Screen for cardiac complications and involve the cardiac specialist, lifestyle measures, and antihypertensives as required. For bone health, itself improves with estradiol, and we may add calcium vitamin D as required. Most important is to periodically screen the child for all comorbidities.
Yeah. Thank you, Dr. Nida. So this was a very clear-cut case, but I will just add one point is for any girl presenting with short stature without any apparent cause, even if there are no clinical signs and symptoms, we should keep a suspicion of Turner's. So coming down to our next case, we have a 16-year-old girl. She has presented with no breast development, no pubic hair, and amenorrhea. Height is 136 centimeter and weight is 27 kg. Both are less than third percentile. The HB is 8.2 grams and her investigations relieved hypogonadotropic hypogonadism, that LH is 0.1, FSH is 0.8. So what is the cause of delayed puberty in this case and how will we manage it? Dr. Ashima, please.
Thank you, ma'am, for showing the case. I'll keep my video off because my network is not very stable.
No
But
problem.
yes, coming to the pointers that we discussed in the approach, as Dr. Richa was mentioned and Dr. Medha reiterated, pubertal assessment is not complete without assessment of growth. In fact, growth precedes the assessment of puberty. And in this case, as we can see, that this child is very short. So if we were to interpret the growth, both weight and height are below the -3 standard deviation for that age. And definitely she is in delayed puberty. So there is something which is more than one axis involved. Second, if we see that her hormones are suppressed, so it is hypogonadotropic and the cause appears to be central because both LH and FSH are suppressed. So as Dr. Richa had initially also mentioned that the cause, we are wanting to look at something which could be transient or maybe permanent. At this point of time, what we have also detected on clinical examination is a low hemoglobin. This further shows that there has to be something more than just a plain endocrinal cause. And the first attempt in this cause should be to evaluate systemic causes. So mind you, if the clinical examination is totally normal and if there is a reason for it to be constitutional or physiological in terms of undernutrition, malnutrition, then maybe we can still consider those causes. Otherwise, in this case, upfront, we would want to go ahead and rule out other systemic causes of delayed puberty. So for example, in this case, because she has anemia, I would want to order a detailed hemogram and anemia workup, maybe take consultation from a hematologist. This could be celiac disease, malabsorption, hemolytic anemia, anything which can cause anemia. And further then treatment would also be focused on treatment of the systemic cause rather than hormone supplementation and more fancy hormonal workup. We would be focusing more here on the workup of systemic cause. That's all, ma'am, for this case from my side.
Yeah, thanks, Ashima. So the important point is there is no hurry in treatment for the hormonal treatment. First, because it is appearing to be, first we have to treat the primary thing, and if the child comes out to be a case of celiac, then we are more confirmed that we are going on the right lines. So coming to our next case, we have a 16-year-old girl. She is presented with no breast development, stage 3 pubic hair and no menarche. Height is 160 centimeter, weight is 50 kg, and hormones are LH is 0.1 and FSH is 0.8. So the key questions are what next, what is the cause of delayed puberty and how to manage it?
So thank you, Dr. Richa at the outset and Dr. Bhanu for inviting me for this important ENDOCON 4.0 and keeping this topic of delayed puberty. As a pediatrician, all of us are trained to see the children up to the age of 12 years. And most of the time, the delayed puberty don't comes to us when we used to do the post graduations. But now adolescent is a part of our day-to-day life. So it's a very important topic to discuss. As discussed by you and the previous two speakers, that our child is actually 16-year-old child with no breast development and no menarche. So this is definitely a delayed puberty. There is no doubt about that. Whenever we think about the delayed puberty, we need to think about the differential about is it a physiological cause or is it a pathological cause. So when we think about the physiological cause, we always think about the CDPG. As Dr. Ashima recently said, that there is a growth that is primarily that is affected whenever we are thinking about a systemic cause or a function, physiological cause. So in this particular child, the height is 150 centimeter, the weight is 50 kg for a 16-year-old child. It looks like to be a normal growth child. So that ruled out the initial one half of the table, that probably this child is not having a constitutional delay of puberty and growth. At the same time, there may be a possibility of functional causes is also on a lesser side. So then we need to see for the gonadotropin. So the next step in the approach to delayed puberty is to decide this is a hypogonadotropic or hypergonadotropic. So as you said, the LH is less than 0.1 and FSH is 0.8. So this is again suggesting that this child is having a hypogonadotropic hypogonadism. So till now, in the initial phase as a pediatrician or as a pediatric endocrinology, my first response is where this child is fitting. So this child is having a hypogonadotropic hypogonadism. You asked about the second question about the what you need to ask in the ST and physical examination. So when we already ruled out the physiological and functional causes, we need to think about the isolated cause of hypothalamic hypopituitary hypogonadism and the other acquired causes of HH. So important is the anosmia, synkinesia, deafness or neurological features, because we know that the GnRH neurons and the olfactory neurons, they go together to the hypothalamus. So they usually present with these associated clinical features. So this is a very important history whenever we think about the hypogonadotropic hypogonadism. Acquired causes, there may be tumor, there may be radiation, there may be injury, there may be infection. So those are the history that is important to take it out in any child presenting with the delayed puberty. In this particular child, there are two other things. Growth I already talked about. Other thing is the normal puberty. So normal pubic hair. So as you said in the beginning, that pubic hair is not an important part of your pubertal development. Pubic hair usually goes separately and other pubertal development goes separately. But in case of functional and in case of CDPG, usually the pubarchy is not there. In our child, pubarchy is there. So that definitely indicating that this child is having a hypogonadotropic hypogonadism, and it looks like to be a permanent. There are still a few causes that can present as a transient hypo, but most probably it looks like to be a permanent cause of hypo. So when we started thinking about the investigation, the first investigation after gonadotropin and in hypothalamo hypo HH is prolactin level, because prolactin level can present as a transient reversible cause of hypogonadotropic hypogonadism. So the prolactin level is also an indicator of many of the exsols, and there are many other conditions, the drug history, that may result in hypogonadotropic hypogonadism. So the important thing, how to differentiate it, you need to do the GnRH stimulation test. So you can do the GnRH stimulation test at this point of time. As a pediatrician, I think this is the time when you need to send the child to the pediatric endocrinologist. Till that time, probably you can make a diagnosis of hypogonadotropic and hypogonadism, and don't start the treatment with testosterone. As a general pediatrician, I've seen many of the pediatricians nowadays started testosterone because they think ultimately the treatment is testosterone. So I prefer to go for the GnRH stimulation test by leprolide or triptorelin, and then I will see the values at the 0 minutes and 120 minutes. If the LH is more than 5 milliunit per liter, then it is level more than 5 milliunit per liter, that is CDPG. If the level is less than 5 milliunit per liter, then it is an hypogonadotropic hypogonadism. So in this way, I can reach to my clinical biochemical diagnosis of hypogonadotropic hypogonadism. Definitely, there are further investigation that is required in this particular child, that maybe you need an MRI in few of the cases in these scenarios. How to, what may be the causes? I already told you there may be central causes primarily, and there may be some receptor related causes. Central causes are isolated. that is GnRH receptor, leptin receptor, KIS1 receptor. I think PCOS is already discussed about a lot of endocrinology. So these are the terminologies are very well heard by the audience right now who is here. So these are the commonest causes that can be the central causes. They may present with some neurological deficit in terms of cranial nerve palsy, or there may be some convulsion and other things that may indicate there may be exalt that was going on. So MRI brain is indicated in those particular scenario when you can think of. How to manage this case? Again, this is the field where the pediatric endocrinology comes in picture. So we need to build up the puberty. We cannot bring up the puberty in very short time. So we need to go very slow, just like the physiological puberty we need to develop. So we need to start with the low dose estrogen that is almost 10% of the adult dose. Then it needs to be gradually increased over 2 years to achieve the menarche, and then maybe you need to start the progesterone at that particular point of time. So a specific therapy is required to treat this particular condition. There are, as a general pediatrician, many times this question is asked, what about the fertility in my child? Definitely the fertility is possible by giving the gonadotropin supplement and the oocyte donation and oocyte ovulation induction, and then oocyte donation can be helped.
Yeah. Thank you, Dr. Mahesh. That was a very insightful discussion. So from the last two cases, we can come to the conclusion that growth monitoring and pubic hair, these are two very important I will not even say investigation. These are the examination findings that we do during the routine practice that will help us to clinch the diagnosis, whether we are dealing with a sinister cause like some central major issue, or it's a simple transient hypogonadotropic hypogonadism or a constitutional delay in the puberty. So coming to our last case of delayed puberty in girls, we have a 17-year-old girl. She has presented with stage 4 of breast development, no pubic hair and no menarche. And in the initial investigations revealed FSH more than 60. So what is the probable cause and how to proceed? Dr. Ashima, please.
Thank you, ma'am. So for all of us, since we've started, we've been talking about knowing normal growth, normal puberty. So very important here to note two things. One, she is progressing in the breast for breast maturation. There is no pubarche, there is no menarche. So there is a clear-cut disconsonance which we are not very comfortable about. And the second, of course, the initial test which anybody would want to do is screen for thyroid, screen for basal hormones, and that show a raised FSH level. Again, this is also something which is very glaringly abnormal. So here, I think the most important thing, first point as clinicians, is to identify what is atypical. So over here, what I feel, this pattern of breast growth is very atypical. The second thing that I would want to be concerned about is how has been the growth in this child. And what I gathered from the case that was built, probably she was not very short. So she's not short, but she is definitely having a disconsonance over here. So can we have the next slide? The third point that I would be interested in knowing is what has been the age of menarche, because here we are actually stuck with a child who's not developed pubarche and menarche. So I would also want to ask about the age of menarche just to complete my workup in terms of whether I've elicited and I'm not missing any other thing. The next thing, obviously, wanting to look at some acquired causes if they have happened any, but most important here would be actually checking we are checking for a discongruent growth pattern where a karyotype will be very, very crucial. So if you go back to recollect how case 1 was presented, where there was a classical Turner's with hypergonadotropic failure, there usually they may not have a breast size which is as good as V4. They would have somewhere around V1, V2. Here we have a child who has a very good breast size but no pubarche or menarche, which means that we want to really check whether she is true XX, or are we looking at a pathology where she has incongruence, that is something which is like a 46XY now presenting completely feminized and now has presented during puberty with primary amenorrhea. So if you look at the causes here, yes, we are looking at chromosomal causes, any acquired causes where pubertal maturation would have stopped, but none of these would have such a great degree of incongruence in terms of breast and pubic hair development. So we are actually wanting to rule out androgen insensitivity also in these cases. And as a rule of thumb, which Dr. Medha also mentioned, all short girls and all those who present with delayed puberties, please get a karyotype as an essential part of workup. That's all for this case, ma'am. Any comments if you want to add?
No, thank you. So I think she have covered everything. Thank you. So from delayed puberty in girls, we move out to the delayed puberty in boys. As we initially discussed the definition, so if there is no development by 14 years, and that here we're talking about the testicular development, testicular volume more than 4 ml, then we label that as delayed puberty. Here again, when we go by the broad, it is constitutional delay or pathological delay. Here, constitutional delay is much more as compared to the pathological. And if we compare about the constitutional delay in girls with respect to the boys, here again, in the constitutional delay, the growth will be less, the all over, the height will be less. And however, in pathological, again, it could be hypergonadotropic or hypogonadotropic. In hypogonadotropic, similarly, we could have functional or permanent. Functional as malnutrition, celiac, similar causes as in the girls, while permanent are comparatively more like Kalaman's genetic or CNS insult or hypopituitarism. And then we could have a central, it could be a testicular issue, direct testicular injury, it could be radiotherapy, chemotherapy, or rarely diseases like mumps. So here we have 60% of the cases which are constitutional, and then we see hypergonadotropic hypogonadism around 20% cases and 10% each of hypo and hypogonadotropic hypogonadism. So now we're coming on to the cases. We have 15-year-old boy, a boy, testicular volume of 2 ml and no pubic hairs. Height is minus 2.5 SD. Bone age is 12 years. LH and FSH are prepubertal. So Dr. Medha, what is the diagnosis and how do we differentiate between how we go forward with such a case?
So as you said, the child is more than 14 years of age and the testicular volume is still 2 ml, that is below 4 ml. So this is a case of delayed puberty. So going ahead with a careful examination, and as you said, we need to differentiate between constitutional delay and a hypogonadotropic hypogonadism. So I've enlisted the features that would help us to differentiate the two. Looking at the height would be retarded in CDGP, whereas it might be normal in hypogonadotropic hypogonadism. Bone age would be retarded. And as you said here also, the bone age was retarded by 3 years. While it would be okay or mild delay in hypo-hypo. As the whole child is delayed, as the name is delayed software update, the child is in delayed software update and the pubic hair is absent, again that would point to CDGP. Whereas the pubarchy proceeds normally in hypo-hypo. Testicular volume is... Sorry. Yeah. Testicular volume is low in both cases. However, it would be less than 1 ml. If the testes and Sertoli cells both have not even developed, so they are less than 1 ml. Seeing a response to gonadotropin releasing hormone analogs and LH and FSH post stimulation, they would be more than 5. They would the pituitary would the LH FSH would rise after the stimulation, so it would be more than 5. Whereas despite the analog stimulation, it would be low, below 1 in hypo-hypo. Inhibin B levels would also be an indicator. It would be more than 50 in CDGP, whereas it would remain low in hypo-hypo. Testosterone levels, basal levels, taking basal levels, it would be more than 20 in CDGP, while it would be less than 20 in hypo-hypo. And HCG stimulated testo would be beyond 200 nanogram per DL in CDGP, while they would be low in hypo-hypo. Having said all this, we need not undertake all the tests. Going by the clinical picture itself, the growth, bone age, and the absence of pubic hair by itself would indicate CDGP, and we need not go ahead with all the tests and follow the child, keep the child in follow-up. So in this case, as we discussed, the testicular volume was only 2 ml in a 15-year-old child, so delayed puberty. And no pubic hair, bone age delayed, so it suggested CDGP. LH-FSH were done already and they were low, so they exclude hypergonadotropic hypogonadism. That was the only thing required. Even if it is low, so the clinical picture has suggested CDGP, and we would keep that as our provisional diagnosis.
Thank you, Dr. Mehta. So now this was a case of a CDGP. Now coming on to our next case, we have a 17-year-old boy who has presented with gynecomastia. The stretched penile length is 7 centimeter and testicular volume is 1 ml and height is 181 centimeter. So here how do we go about this? And here we see a child whose height is normal and has mainly presented with gynecomastia. So Dr. Mahesh, please go for it.
Thank you, Dr. Richa. I think, again, we go back to our definition. So if we go back to our definition, there is an absent testicular development by 14 years of age is a delayed puberty. So this child is having definitely a delayed puberty. But there are few things that strikes our mind when we are reading this particular thing. The SPL is 7 centimeter. So that is one point that probably we are not expecting that SPL in a pre-pubertal child or in an early puberty. So definitely there is some pubertal development that started in that particular child. If you again go through with this particular parameter that we are talking about, those parameter is saying there is an associate, there are pointers. So this pointer, one pointer is there is a gynecomastia. Other pointer is the height 181 centimeter. And this is the importance of putting the height on the growth chart, because this 181 centimeter is definitely a tall stature child. This height is more than expected for this particular age in that particular child. But at the same time, you need to consider the mid-parental height where this child's height is fitting. So there are few things that is going against the norm. So this is a delayed puberty with a normal SPL at that particular point of time, with gynecomastia and with height. So the important thing in the history is you need to ask, is the inadequate progress or there is a regression of pubertal changes? That is the one important history that you need to ask, that at any point of time there is a changes, pubertal changes started and then they become stuck. So you need to differentiate, this is really a delayed puberty or this is a stalled puberty. So these are the two important questions in a child in a boy who is presenting with delayed puberty. If it was complete within approximately 4 years of onset. So these are the two things that is the common questions that we need to ask at that particular point of time. How we need to approach? So again, the history taking that is the most important thing. And as I told, there is in tall stature, you need to see the other anthropometric parameters. So arm span is very important. So in this particular child, the arm span is definitely on a more. There is a small and shorty testis. So the palpation of testis in this particular condition is very important. This is more than 1 centimeter, 1 ml. That what Medha is talking about. Usually hypo has a less than 1 ml. So this is more than 1 ml, and this is a small and shorty testis. The breast bud size you need to check, and if there is an associated behavioral issues. So these are the few things that you need to see in your examination. So by taking the detailed history, in my particular child, the child is having a stalled puberty with normal SPL and small testis, with gynecomastia, with tall stature. So if you just click it out, I think this is just opposite what we are talking in the girl, going toward the hypergonadotropic. So Turners we usually see in a children in the girl child presenting with and in a male child. Definitely this is the important history that you need to find out. So you need to go for the investigation. So the investigation gonadotropin, when we did in this particular child, the LH and FSH is on a higher side. The LH is 0.2. Sex steroid, the testosterone is on a lower side. And the estradiol is 60 picogram per ml. That is again on a lower side. On a higher side, estradiol and testosterone ratio is also high. So this is clearly indicating that it is a case of hypergonadotropic hypogonadism, indicating the primary gonadal failure. So the commonest diagnosis that we usually make at this point is the Klinefelter syndrome, though there are other possibilities also. There may be a rare XX male that can present in this way. Sometimes the anorchia child can present with hypergonadotropic hypogonadism. And there is a disordered steroidogenesis also sometimes present with the hypergonadotropic hypogonadism. But seeing the tall stature and the gynecomastia, they are the clincher with hypergonadotropic towards the Klinefelter syndrome. So the most important investigation is the karyotyping. So once you made it, they have karyotyping, there is an extra X. So this child is having a 47XXY. So this child is confirmed Klinefelter syndrome. The associated anomalies, just like Turner, it has a lot of many associated anomalies. Similarly, Klinefelter has a very many association. The most important is the mediastinal germ cell tumor. That's what we usually see. And this mediastinal germ cell tumor sometimes present as a precocious puberty also. So in a child with a Klinefelter syndrome, both the conditions are possible. There may be a possibility of more possibility towards the delayed puberty, but there is a rare possibility of precocious puberty also in the Klinefelter syndrome. They may present with the type 2 diabetes mellitus. There is an associated coronary artery disease, osteopenia and osteopetrosis. These are the commonest thing that what we usually see in these particular children. Behavioral disorder are associated. So these children usually have an autistic spectrum disorder. There are infertility is also associated with these particular children. Though there is a possibility that by using some drugs and by the newer methods of reproduction, that these child can also can have some fertility chances. But the important treatment is definitely the testosterone. Again, we need to build it up as a normal testosterone upgradation in the body. It should not be the rapid change that should be there. So I think this looks like to be on the basis of history. The key message I wanted to give is the one thing that is very important, always see the history and anthropometry. That is the most important part. And in children with hypergonadotropic hypogonadism, karyotyping is must.
Thank you, Dr. Mahesh. That was a very nice explanation of all of a case. So we go forward to the next case. We have covered all the topics. We have a 16-year-old boy with a testicular volume of 2 ml, no pubic hairs, and we see LH and FSH are on the lower side, less than 0.2, and associated anosmia is there. So Dr. Ashima, please discuss this.
Okay. Thank you. So what we cover here in boys is almost like a recapitulation of what you've been hearing since start. So we can skip this slide for now, ma'am. But I hope the audience would now be able to relate to that this is a hypogonadotrophic hypogonadism that we are talking about, where the basal LH, FSH are really low. And among the causes, we would want to work for genetic acquired either cause. So this slide actually sums up the approach of delayed puberty that we've been talking about in girls and boys both. So the first is that if we have ruled out systemic illness, we've taken a good history, we've done a growth assessment. After that, the first thing that we would order is a basal LH-FSH. If the basal LH-FSH is low, then we would want to rule out, that means that this is a central cause, as was in the last index case. So the most common things first, so we would want to rule out CDGP, transient causes like malnutrition, any acquired endocrine causes like hypothyroidism, or any chronic illness. So by and large, these are commoner causes of delayed puberty in any pediatric practice. And if these causes have been ruled out, then we would be looking and investigating for hypothalamic pituitary causes, where the role of GnRH stim test would be useful, which Dr. Mahesh and Dr. Medha have already covered well. If confirmed as hypo, then these children need hormone replacement therapy. So for boys, it is actually testosterone esters available as injections in this country, which have to be given at a frequency of around 3 to 4 weekly. So again, like for girls, we build it up the dose gradually. For boys also, we would build up the dose gradually. So best here would be to refer the child to a pediatric endocrinologist or an endocrinologist to take forward the care from here. If the basal LH-FSH are high, that means that there is loss of negative feedback from the gonadal axis. So we are looking at causes which cause end organ damage or problems in the gonad. So for girls, it would be most common Turner's, and for boys, as the last case which Dr. Mahesh discussed, was Klinefelter's. Also, other causes where there could be gonadal involvement in terms of irradiation or autoimmune damage. So here also, the workup for underlying cause would include your karyotype, any antibody test that you would do, and the trial of treatment would again remain the same. So principles of treatment and HRT would be the same, but syndromic causes we would be more worried about ruling out other associated problems. So that has to be done with a multidisciplinary team. And finally, counseling to the parents of what the child has, what is the fertility potential of the child, how long should that HRT continue, and a handover to the adult colleague at the end of say 16, 17, 18 years, once the child is now an adult of adult age, so that he's taken care equally well by the adult colleague, because these conditions are unlikely to be resolving or remitting by the time they reach adulthood. So that transition of care and closure of loop has to be completed for all these children whom we have been treating for the last few years. That's all, ma'am. Thank you.
Yeah. Thank you, Ashima. That was a very nice recapitulation of all the of the whole presentation, and I have nothing more to add. So the basic approach remains the same as has been discussed: proper history, proper examination, and the baseline investigations. We don't need to investigate completely every child. We have to choose which child to be investigated and which not to be investigated. And second, and very important take home is, when we treat this child, the treatment has to be like in a normal puberty. We have to give slowly. We cannot give very high doses, neither to the girls, neither to the boys. So this has to be very closely monitored. Thank you. I tell the chair, I give over to the chairpersons for the discussion.
Thank you for the nice discussion. So it was an eye-opening, and for a practicing pediatrician, it was very important. I have one question. Mainly, we see a lot of boys with constitutional delay in puberty. So, is there any, besides monitoring, is there any role of giving testosterone? And if we can give it on OBD basis, so what dose can we give?
Dr. Mahesh, would you like to take this case or take the discussion?
It is really not required. That's what we are talking about. So the testosterone therapy is really not indicated in condition of CDPG. If you are very sure that the child is having a growth retardation of 2 to 3 years, with a bone age is also showing some 2 to 3 years of difference, there is a family history related with in that particular child, there is a delayed shaving by the father. Then there are many indicators that will say that probably this child is having a CDPG. So in that child, you just need to monitor that particular child. It is really not indicated.
Okay. Because many times the parents are very frightened and they are very much worried. So even after repeated counseling, so they want some therapy. So that's what.
So Dr. Ashima, Dr. Richa, if you have anything wanted to add?
So yes, it according to the guidelines, they say if there is psychological issues, these are causing psychological issues. So after 14 or 15 years, we can give a very low dose testosterone to start the to induce the puberty, and that dose has to be only 25 milligram. That has to be given once or twice, only maximum 2 to 3 times. And that usually induces the puberty on its own. But that is only after the consultation with the parents, and the child has to be under very close follow-up.
So what I've seen actually, when someone start this, they know that there is a response to this particular injection. They go to the another pediatrician, then he will again repeat it. So there may be many.
That is very important. It has to be under close follow-up, proper counseling. We cannot just keep giving it.
Right.
Because
so maximum how many doses you can give?
Not more than 3.
Oh, thank you. Thank you very much.
Yeah, I would also like to add, this is Dr. Bhanu. I would also like to add to reiterate what Dr. Richa is saying, that is in such a situation, there are some instances where when the process is really delayed and you think that before evaluating for something like a hypogonadotropic hypogonadism and all, better to give one trial of androgens, and usually low doses. So what we give is 50 milligram once a month for the total 3 doses, and it, as it has already been said, that it will certainly produce some effect. Now, some effect means that there would be some phenotypic changes that the parents will notice, that the looking at him, the child looks different now, a little different. Some androgenic features are there, but that would not be sufficient enough to produce because the pubertal full pubertal level of testosterone are in the range of 250 to 300 milligram per month. So, but the purpose it does is that it gives it, in common terms, it is called as androgen push. We call it as an androgen push, and primarily the purpose of androgen push, since we know that the sex steroids, they advance the bone age, also advance the overall development. So what they do, that in the cases we are suspecting constitutional delay in puberty, this small push by the androgen, we expect that the body clock will proceed with a little higher speed and reach to the developmental stage where the spontaneous puberty should come. So it works, I would say around 50 to 70% cases it works, but in 30% cases you need to do the further evaluation.
Okay. Any other further questions? So I think we are done with the questions. Thank you, Dr. Vipin. So Dr. Bhanu, we have finished well on time.
Yeah, I'm noticing. Yeah.
So I would like to just thank Dr. Medha, Dr. Mahesh, and Ashima for a very nice discussion. And I hope this discussion has been helpful to the general practicing pediatricians for their day-to-day activities. So I will thank you all, and Dr. Bhanu, all the chairpersons, all delegates. I hope we all have learned today, and our few doubts have been cleared, and these knowledge points will help us in our day-to-day practice. Basically, when we talk about adolescent endocrinology, I think we need the help of pediatricians, pediatric endocrinologists, obstetricians, and general physicians in total to cater to it. So with this, we end our session, and I hand over to Dr. Bhanu for the closing remarks.
Thank you, Richa. I'm not switching on my video because it's showing low bandwidth. Okay, so certainly it was a short and sweet meeting and a good catch up with friends, as well as discussion on some of the very common case scenarios which keep haunting us. It's because it's no child comes with a garden variety of symptoms, and every child comes with a new constellation, and everyone has to put the thought process going on. So, and I am certain that this discussion done by our dynamic speakers and our panelists, they have certainly brought out some of the insight into the overall scenario, and it will be quite fruitful. And yes, this is commendable that we have finished in time. Yeah. So thank you everyone.
Thank
you so much.
Thank you. Thank you.
Thank you, everyone. Thank you.
Bye, Dr. Medha. Bye, Ashima.
Dr. Bhanu.
Thanks, Mr. Zuzer.
Thank you, ma'am. Yeah.
Thank you. Thanks for being on the back end.